Nessuno e nessuno, sì, ma insieme siamo tutto, io e te.
L'età non conta, quella è solo per le più.
E quando son conteggio giù, il mio pacemaker va in tilt.
Nessuno e nessuno, sì, ma insieme siamo tutto, io e te. C'è sempre qualcuno che ti fa stare su.
Non c'è sempre qualcuno che ti ama come me.
Nessuno e nessuno, sì, ma insieme siamo tutto, io e te.
Questa era Insieme siamo tutto, perché come forse avete capito, in TV presto la voce a un gatto blu che si chiama Gumball, mentre invece Maura Cenciarelli presta la voce a Darwin, che è appunto mio fratello, e questo rende Maura mia sorella e questo mi manda subito in confusione. Ma a parte tutto questo, ci sono state anche le nostre sigle. Ve ne facciamo sentire una, è quella di Spirit Riding Free.
Abbiamo il mondo davanti, questo viaggio io e te. Cavalcare, cavalcare insieme a te. Un'emozione ancora più forte perché ti ho vicino a me. E così, sì così, sì così, e così insieme io e te. E così, sì così, sì così, e così insieme io e te.
Spirit Riding Free. Spirit Cavallo Selvaggio, questa è la trasposizione televisiva, la serie, di cui appunto abbiamo realizzato la sigla. Però quello che non vi ho detto è la cosa più importante, perché abbiamo deciso di chiamare questo show Quando i bambini fanno rock per Parent Project. Sì, perché Quando i bambini fanno rock è il titolo di questo disco. È un disco che abbiamo realizzato insieme a Teorema. Gruppo Teorema è la nostra etichetta discografica e è uscito da pochi mesi e non contiene sigle televisive, che è quelle che solitamente facciamo, ma musica per l'infanzia, i grandi classici della musica per bambini rivisitati in chiave rock, accompagnati da una band di baby musicisti, di fenomenali piccoli batteristi, chitarristi, bassisti, un coro di voci bianche, e tutto questo lo abbiamo messo a disposizione devolvendo gli incassi nel mese di dicembre a Parent Project e abbiamo realizzato dei piccoli video live durante questo show digitale. Ve ne faccio vedere uno.
Il caffè della Peppina non si beve alla mattina né con latte né con tè, ma perché? La Peppina fa il caffè con la cioccolata, poi ci mette la marmellata, mezzo chilo di cipolle, 4-5 caramelle, 7 ali di farfalle e poi dice: che caffè! Il caffè della Peppina non si beve alla mattina né con latte né con tè, ma perché? La Peppina fa il caffè col rosmarino, mette qualche formaggino, una zampa di tacchino, una penna di pulcino, 5 sacchi di farina e poi dice: che caffè! Il caffè della Peppina non si beve alla mattina né con latte né con tè, ma perché? La Peppina fa il caffè con pepe e sale, l'aglio no, perché fa male, l'acqua sì ma col petrolio, insalata, aceto e olio, quando prova col tritolo salta in aria. Col caffè! Il caffè della Peppina non si beve alla mattina né con latte né con tè, ma perché? Il caffè della Peppina non si beve alla mattina né con latte né con tè, ma perché?
Wow, spero vi siate divertiti. Un saluto da me, da Laura e da Dario, che non sono qua ma sono virtualmente con noi, e adesso vi lascio a una sessione sul presente e il futuro della ricerca clinica e farmacologica. La seguirò con interesse anch'io. E anzi, per darmi un tono, vi lascio con un quesito che peraltro già ci siamo posti durante la diretta di dicembre, un quesito scientifico. Ma il coccodrillo come fa?
Oggi tutti insieme cercheremo di imparare come fanno per parlare fra di loro gli animali. Come fa il cane? E il gatto? L'asinello? La mucca? E la rana? La pecora? E il coccodrillo? E il coccodrillo?
Il coccodrillo come fa? Non c'è nessuno che lo sa. Si dice mangi troppo, non metta mai il cappotto, che con i denti fuga, che molto spesso pianga, però quando è tranquillo come fa sto coccodrillo? Il coccodrillo come fa? Non c'è nessuno che lo sa. Si arrabbia ma non strilla, sorseggia camomilla e mezzo addormentato se ne va.
Guardo sui giornali, non c'è scritto niente. Sembra che il problema non importi
A chi?
alla gente. Ma se per caso al mondo c'è qualcuno che lo sa, la mia domanda è ancora questa qua.
Il coccodrillo come fa? Non c'è nessuno che lo sa. Si dice mangi troppo, non metta mai il cappotto, che con i denti fuga, che molto spesso pianga, però quando è tranquillo come fa sto coccodrillo? Il coccodrillo come fa? Non c'è nessuno che lo sa. Si arrabbia ma non strilla, sorseggia camomilla e mezzo addormentato se ne va.
Adesso ripetiamo, se vogliamo ricordare, come fanno per parlare tra di loro gli animali. Come fa il cane? E il gatto? L'asinello? La mucca? La rana? E la pecora? E il coccodrillo? E il coccodrillo?
Il coccodrillo come fa? Non c'è nessuno che lo sa. Si dice mangi troppo, non metta mai il cappotto, che con i denti fuga, che molto spesso pianga, però quando è tranquillo come fa sto coccodrillo? Il coccodrillo come fa? Non c'è nessuno che lo sa. Si arrabbia ma non strilla, sorseggia camomilla e mezzo addormentato se ne va.
Allora, avete capito come fa il coccodrillo?
Lui mezzo addormentato se ne va.
So in 1984, a long time ago, my boys, two of my boys, my only two sons, were diagnosed with Duchenne muscular dystrophy. So at that moment, you feel quite alone and really unknowing about what happens next or what you should do. So I reached out to physicians, and most of them had never even heard of Duchenne, or if they'd heard of Duchenne, it was very briefly in their medical school career.
La distrofia muscolare di Duchenne è la più complessa tra le patologie genetiche che riguardano il muscolo. Di fatto è presente dal concepimento, quindi alla nascita tutti i bambini che hanno la distrofia di Duchenne di fatto già la portano con sé, e compromette la rigenerazione del muscolo. Tutti noi utilizziamo il muscolo qualsiasi cosa facciamo, ma noi lo ricostruiamo quotidianamente. I bambini che hanno la distrofia no.
So I went on this journey to find that out, and it took some time because people, it was hard to find and there wasn't much research. And so I felt like what was missing in this whole environment is the patient voice, right? Because parents, and certainly boys with Duchenne or individuals with Duchenne, have to have a voice in here because it's about their lives and about the quality of their lives. So I felt that was really missing.
Io credo che come tutti i genitori che ricevono una diagnosi di Duchenne per il loro figlio, la prima cosa che si cerca di fare è di cercare informazioni, e quindi Parent Project in Italia è nato per questo.
It was really hard to find out because, first of all, way back then, which seems like the old age, right? We didn't have social media, we didn't have Facebook, we didn't have the ability to connect to other families.
Nel corso di questa ricerca entrai in contatto con alcuni genitori americani, in particolare con Pat, e allora decisi di aderire a questo movimento internazionale che stava nascendo, che si chiamava Parent Project.
So I took a loan out at the bank, and then I ordered all the publications around Duchenne to understand what we knew about Duchenne. And then I made appointments at different laboratories and different clinical offices and pretended to be a doctor and asked them questions about what do we know about Duchenne.
Quindi in quel periodo la cosa più difficile è stata proprio esattamente capire cosa fare e come farlo, quindi cosa spiegare alle famiglie, come insegnare alle famiglie ad affrontare questa malattia da un punto di vista clinico e soprattutto anche da un punto di vista psicologico.
So I think the fundamental issue is that this child is the same beautiful child, and that their path is going to be far different than anyone predicts because it's unknown but full of promise.
I'm Elizabeth, and I'm the mother of Justus. Justus is now almost 28, 27 and something. And I live in Amsterdam, or we live in Amsterdam. Justus is my son with muscular dystrophy, which we know for a long time already. And meanwhile, he's just doing whatever he likes to do, and I'm also doing what I like to do.
I'm Laura, and I live with my husband Philip and our wonderful two boys. Louis is 7 years old and Jensen is 5 years old. We live in a little small village, Lancashire. It's very, very small.
Mi familia está compuesta por tres personas, que son Isaac, que es el papá de Alonso, Alonso y yo, la mamá.
Suntem o familie normală, de oameni obișnuiți, avem 25 de ani de căsătorie și suntem doi oameni care au avut vise foarte mari în viața lor, au făcut sport, au călătorit, au iubit natura, o iubim în continuare și avem un băiat minunat de 21 de ani, Petru, care este centrul atenției și preocupărilor noastre.
אני טלי קפלן, אני נשואה, יש לי 3 ילדים, עידו הקטן, בן 10, שירה בת 15 וחצי, ואורי בן 14.
Y Alonso nacía por querer estar de pie cuando todos los niños empezaban ya como a trepar y sobre todo a la hora de sentarse, tardó mucho en sentarse y cuando se sentaba se caía para atrás. Yo le tenía que poner cojines detrás para que no se cayera.
We went to see another consultant and we all got into the room and he got Louis pressing and running and he just came out with the words where he's got muscular dystrophy Duchenne. And from that moment on, I don't think I heard any other words.
First thing I thought was, but we have time. No, he had a twin sister and she died after 4 days. Then I thought with Duchenne, you know, it's a shorter life, but it's still, we have 20 years ahead of us. So we're going to make the best out of it. So I remember when we drove down back from the hospital, I said to him like, we have time, you know, we have time. We're going to make the best out of it.
El caso es que yo pensé que durante unos meses no quería relacionarme con nadie que tuviera Duchenne, ni quería oír hablar de asociaciones, pero una vez que pasaron todas esas fases, despierta una fortaleza que no sabías que tenías. Eso es lo que me ha pasado.
אבל מצד שני זה משנה את כל החשיבה שבעצם אתה מבין שהמטרה היא מה שנקרא לייצר חוויות ולחיות. ושהרבה דברים בעצם לא תלויים בנו.
Și din acel moment, de la vârsta lui de 6 ani, am decis să fac din mine cel mai bun părinte posibil. Și cel mai bun părinte posibil era părintele care investește timp, atenție și care este el însuși foarte echilibrat.
When Justus was just diagnosed, I thought, like, can I still laugh, you know, and have fun when your child has such a diagnosis? But then I realized that if he would have Duchenne and a depressed mom, that he would have a double problem.
Yo creo que feliz, yo creo que él está bien, tiene amigos en el cole, tiene amigos aquí en el barrio y él juega, le gusta jugar muchísimo al fútbol y yo le veo feliz.
Louis is a lovely little boy, he's a character, he's always smiling. We have fun, we have fun.
Y lo que cambió sobre todo es nuestra forma de ver la vida. Es decir, dar menos valor a cosas que antes eran muy importantes y que significaban verdaderos problemas para nosotros y en ese momento todo pasó a ser un segundo plano y nos dedicamos a vivir el día a día y a disfrutar de Alonso.
Petru este un tânăr foarte pozitiv. Este un tânăr... Pentru mine, Petru este ca o lumină. Este capabil să înțeleagă lucruri profunde doar dintr-o singură privire. Este atent la suferința oamenilor din jurul lui.
So when Justus was young, I realized a few things. One is that he should be resilient. You know, if a child is afraid for everything and goes home or stays at home, that would not be good for his future. Second is that the way you're treated is also 50% is yourself. Justus just graduated from university, and he always, for him, it was very important. He just wanted to do things normal. He never wanted Duchenne to be too big in his life or to change his life too much.
כשהוא היה בכיתה א', רציתי בעצם לדעת מה באמת הוא יודע, כדי לדעת מה להגיד לו. ואז גם בבית הספר הוא התחיל לקבל טיפול רגשי, כדי באמת, הוא התחיל אז יותר להתמודד עם התסכולים ועם הקשיים הפיזיים יותר, אתה מתחיל בעצם לראות שקשה לך יותר לרוץ, או שכולם רציקים יותר מהר ממך ואתה לא...
Y aunque parezca ridículo para muchos que están viviendo ahora Duchenne en sus peores fases, después del diagnóstico, que ese es el varapalo más grande, fue en el momento que tuve que asumir que Alonso tenía que empezar a tomar corticoides, porque es una forma de decir que la enfermedad ya está aquí.
Petru a suferit cel mai tare când a fost părăsit de prieteni, în momentul în care el n-a mai putut merge. Încât s-a închis, a refuzat să mai iasă, a refuzat să mai meargă la școală, a refuzat să mai vină oameni la el, să mai lege prietenii, a preferat să aibă prietenii virtuale pe aceste forumuri de discuții. Camera lui e universul lui și să nu-l mai deranjeze.
My anxiety, it is still there, it is. I don't cry no more. I probably cry every couple of months. I have a really bad day, but I've learned to deal with it now. It's there.
המסר המשמעותי להורים החדשים שמאובחנים זה שהם לא לבד, שאנחנו כאן איתם, ושהעולם של דושן ובקר משתנה. והדבר הנוסף הוא שהשמש עדיין זורחת. זאת אומרת, עם כל הקושי, הילד שלך הוא עדיין הילד שלך. עדיין המטרה היא שהוא יהיה שמח, שהוא יהיה ילד. לא צריך להפיל עליו את כל הקושי הזה של המחלה, ולא להסתכל על כל מה שכתוב, אלא לחיות כאן, לחיות עכשיו, ופשוט ליהנות ושוב, ולזכור שהוא ילד, ללכת לגן שעשועים, ואתם לא לבד.
Odio Duchenne. No ha aportado nada positivo a mi vida, solo conocerme un poco más.
Everything they get, next step, they never can go back to a better level, so that's the bad part, I think. Yeah.
El tiempo que no se lo estamos dando ahora es porque estoy segura que van a disfrutar de él más adelante, porque estamos luchando para ello, para que cada vez Duchenne esté más lejos de nuestras vidas.
Time isn't on our side for our boys with Duchenne. We need drugs, we need them now. We haven't got tomorrow, we need them today.
Here in the Netherlands, we have good things and bad things. What is not good is that drugs for Duchenne are not reimbursed.
În acest moment, situația generală pentru pacienții Duchenne în România este destul de inegală la nivelul întregii țări. În general, cred că povara bolii, povara dizabilității cade pe umerii familiei. Cel mai valoros lucru și cel mai pozitiv lucru din viața mea, care s-a întâmplat datorită distrofiei musculare Duchenne, este valoarea fiecarei clipe împreună. Valoarea dialogului simplu și uman cu oricare dintre interlocutorii tăi, indiferent în ce poziție de putere sau de decizie se află el.
Yo creo de verdad que Alonso no va a vivir todo el desarrollo de Duchenne que ahora mismo conocemos. Quiero confiar en que todos los avances que hay ahora mismo, si bien la cura está lejísimos, sí que vamos a ir poniendo parches a Duchenne.
These boys are not afraid of what's happening to them. Where should we be afraid for? When your child's in a wheelchair, he's still the same boy, you know? And he's still the nice kid, and that continues. So don't be afraid. And as I said, I feel that I became quite fearless because of this diagnosis, and that feels good.
They want to see happy mum and dad, they want to have fun, because these little boys, they don't know what Duchenne is, they don't know what their life's going to be like. They just see today, they see going up the stairs to play on their Xbox, they see going to the park. You know, I think us as parents, we worry about what's going to happen next year or the year after, and I think just relax.
Tu hijo tiene Duchenne, pero tu hijo tiene un nombre, tiene unos amigos, tiene un colegio, es un niño. Entonces, disfruta de él y ve acompañándole en cada paso y ya está. Para luchar contra Duchenne, pues ahí tenemos a los científicos. Nosotros solo tenemos que dar cariño al niño, igual que cualquier padre, y nada, y vivir con esperanza, nada más.
Noi nu ne permitem să amânăm pentru a doua zi lucruri. Noi nu ne permitem să spunem că ne vom lua revanșa față de copiii noștri, nu acum, pentru că suntem ocupați, mai târziu. Noi nu avem acest lux de mai târziu. Și asta m-a adus pe mine să trăiesc mult mai bine în prezent și să încerc să mă bucur de fiecare lucru mic care mi se oferă într-o zi.
זה תהליך ארוך ללמוד לומר בזכות ולא רק בגלל. שהרבה דברים הם לא בגלל המחלה אלא בזכות, כי כן, דברים השתנו. מן הסתם זה לא משהו שבוחרים. בלי האבחון הזה, אז הכיוון של החיים היה אחר לגמרי. זאת אומרת, זאת הייתה לגמרי בחירה לעזוב את מה שעשיתי קודם, כי ההבנה היא שאם אנחנו כהורים לא נפעל לשנות את החיים של הילדים שלנו, זה לא יקרה. ואנחנו כהורים, שיש לנו באמת את הרשת ארגונים הזאת ואת ההורים,
Hope is not only hope for a cure, it's also hope for a good life. It's hope to have fun, hope that things go well, you know, and also hope that what you do will help a lot of people. That's also my hope.
Pero no, o sea, la esperanza que nosotros damos no es una esperanza fingida, es que esta asociación desde el principio hemos tenido claro que teníamos que luchar con positivismo y esperanza, pero una esperanza real, yo no me la invento.
Be realistic about them. Don't be disappointed if there's not a cure tomorrow or something. And above all, I would say enjoy life. You still have a beautiful child.
Aunque mi hijo tenga 8 años y yo no sepa cómo, si voy a vivir ese final hombre, a ver, quiero vivirlo, pero si no es así y llega más adelante, sé que he hecho algo para ello.
Be optimistic. Hope keeps you alive.
Buon pomeriggio a tutti, siamo arrivati alla quarta giornata della nostra 18ª conferenza internazionale sulla distrofia muscolare di Duchenne e Becker. Come sapete siamo qua dal nostro ufficio, che per l'occasione è diventato un po' uno studio televisivo in via De Francisci a Roma, da mercoledì ormai, quindi sono ormai diversi giorni che trasmettiamo e felicemente insieme a voi. Approfittiamo per salutarvi tutti quanti, sia tutte le famiglie che ci seguono collegate.
Well, we wish to welcome all the families that are following us and also the many families who are following us from abroad. We haven't met them for 2 years now. Some initial announcements. As you know, we have simultaneous translation into Italian and English, so you can select the language on the Zoom bar and you decide in what languages you want to listen. And please, I ask all speakers to speak slowly. That applies also to me, of course, so that interpreters can work properly. And I wish to thank our interpreters that have been with us since Wednesday, but they've been with us, in fact, for many years. And well, now, of course, they are working in remote, which is certainly more difficult. Thank you very much. And we start with this session with a small extra. On Wednesday, we launched the Easter campaign. The campaign has started, and today, well, we open for all of you the possibility of booking our Easter eggs. And they are a bit like the Italian panettone. So this cake, this special cake that has the shape of a dove in Italy, so they can go to all Italian cities, to our families, but also to the families of many countries, and reach all of you to celebrate Easter together. So you can start sending your orders to the cell number that you can see down along the line on the screen, and then at the end of the session we'll inform you about the first order and how many orders we received. So please send your messages and start ordering the doves. This having been said, we start the session.
La gestione clinica della distrofia muscolare di Duchenne e Becker. Come è stato per le sessioni precedenti, l'idea è sempre quella di parlare di ciò che accade oggi e di quello che potrebbe accadere domani, e quindi parleremo del presente e del futuro della gestione.
So we are going to speak about the present and the future of clinical management together with Dr. D'Amico and other researchers of companies who are developing these clinical studies. We are speaking of the present and the future of clinical management, and there are two important things to be remembered. First, the guidelines on the clinical management for families for DMD and BMD. This is a material you can find in Italian on our website, but also in the conference website. And the second one is the brochure on clinical trials updated to this year, and that again is on the website of on our website. I asked the production to send us the slide with the QR code. You'll be seeing the QR code on the screen. So if you put your cell phone on the QR code, you can see the brochure. And now I give the floor to Gloria Antonini, and she's going to chair the session. She's a member of the scientific committee of the center. You have the floor, Gloria. Good afternoon. We have had some problems with the line. There is the volume going up and down, but you can try again. Yes, yes, we can hear you. I can hear you. Vanna can hear you. Alessandra has a technical problem.
Ok, Gloria, vai. Perfetto. Allora, iniziamo questa sessione che ha appunto l'obiettivo.
So we start this session, and the objective of the session is studying a fundamental aspect for the present patient. So the clinical management, as we did in the past. So we must start by talking both of what care is about. We are considering the different treatments, and we'll also be speaking about the present and certainly of the future. And Fernanda told you about the materials that are available to all. You can download them from our website for clinical management of DMD and BMD. And it is a great pleasure for me now to introduce the first rapporteur of this session, that is Dr. D'Amico. She won't be here with us now because she had another commitment. She recorded her video, so she will take the floor. She will be with us later for the Q&A. She's a neurologist at the Bambino Gesù Hospital in Rome. Many of you certainly know that. And she has a very long experience in the clinical management of pediatric patients with DMD and BMD. So Dr. D'Amico, with her presentation, will be speaking about the clinical management of the pathology, how important it is to have a multidisciplinary care, steroid therapy, of course, the positive and negative aspects of taking glucocorticoids, and the possible existence of problems linked to fracture and bone health, respiratory, heart problems, nutritional problems, and the access to, investigational therapies that will be also the subject of the other presenters. I hope that now the sound is okay. Thank you. And now we can listen to Adele D'Amico.
Buongiorno a tutti, ringrazio prima di tutto l'associazione per avermi invitato a questo evento, sempre con piacere partecipo, e oggetto della mia presentazione è la
I'm very happy to be here, of course. The object of my discussion is the diagnosis and the management of DMD patients, of course, thanks to the international guidelines that were drafted in 2010 and reviewed in 2018. So you have a very detailed description of what the situation is like in these patients. And one of the main things to be underlined here is that in reviewing the guidelines, the authors have stressed the fact that the patient, together with his family, should be placed at the very center, together, of course, with the physician who's supposed to help the family through, also helping them through the different possible therapies that their child may undergo. And they also say that the therapeutical approach has changed. Now the model has become completely different. Now the figure of the case manager is supposed to be always there at all different stages of the disease, being on the side of the family all through the workup, possibly even with the help of a psychologist. And of course, the family will have to somehow share their decisions, their possible therapeutical decisions with the physician. Actually, this figure, the case manager, should be made aware of whatever pertains to the disease, but also he or she should be made aware of the genetics behind it. So what is the mutation involved, and how can this act on a certain number of aspects, including the behavioral ones. Of course, the ultimate goal is to always be on the side of the family, supporting them. Now, of course, during the very first stages of these boys' management, trying and having a clear clinical framework is of paramount importance. So whole management pathways is started based on the guidelines, but also customized. Therefore, one needs to know about the actual resources of the child and, of course, of his family. So everything must be, I repeat, sort of tailor-made. So, as I said, the case manager should be very well informed about all clinical aspects of the disease, including the factors that, as years have gone by, have modified the natural history of the disease, which may have entailed some physical therapy or corticosteroid treatments, and even some respiratory aids. So if one knows about this, well, then the case manager can try and help the families based on a sort of a clear-cut timeline. This might not look very nice, but it is really what gets particularly relevant for case managers and their patients. Indeed, we know that until LOA, until the loss of ambulation, there may be several things that can or shall be done. Maybe this will take a pneumologist or a rehabilitation specialist, especially when the boy starts losing, of course, the ambulation skills. And the same goes for all cardiological issues. We know the relevance of the heart in this disease. So going back to steroids, of course, we know how well established the steroid therapy now is. This therapy should have a daily regimen, possibly prednisone. Actually, the best possible time is before the boy starts a clinical decline. But we must know what the aims of the treatment are, as well as its side effects. So the aims are increasing ambulation timing, and of course, trying to reduce the risk of scoliosis, delaying respiratory failure, but the side effects are all listed on the left-hand side of the slide. And the point is that whenever this may be the case, those responsible for the therapy shall have to adjust it to the newly arising side effects. And then endocrinology. Well, of course, endocrinology should be considered before steroids are started. Well, stunted growth is probably the main issue here. We know that this is quite normal, which has nothing to do with health as such, but it certainly is a problem of a social nature. However, this can be considered by evaluation evaluating, of course, the bone, the actual bone age, and then the boy should be monitored as time goes by in order to see whether there is something specifically that is responsible for such growth stunting. And then puberal delay. Well, of course, we need to understand about the possible sexual development through endocrinology, and we know that this must probably be tackled with testosterone. Well, we don't really need a replacement therapy here, but a therapy that may just be administered in a few cycles, and that will be it. And to conclude, we should remember the iatrogenic aspect of steroids. Therefore, we know that within our adrenal gland, there's no cortisol production, hence the relevance of informing the family of the possibility of a cortisone therapy whenever steroids are administered on at a particularly early stage. Another comorbidity of steroid therapy is osteoporosis. Of course, the disease as such may be changed by this disorder, but of course it may go hand in hand with the steroid therapy. Actually, as you can see, we have 20 to 60% of patients who develop long bone fractures with an early loss of ambulations. Hence, the relevance of constantly monitoring the bones and possibly using calcium in these boys' diets, as well as vitamin D, not to mention possible supplements. And then, of course, one should also consider the boys' postures, in which case biphosphonates seem to be accounting for the best possible therapy. As for respiratory problems, well, I won't go into them in detail, but of course, we know that they account for a major cause of death in these boys. There's some fatigue in the beginning, but then there's an airway impairment with infections and respiratory failure. For all of this, there are a lot of things that can be done with the respiratory aids, for example, thus ventilating even the distal lung areas. And then, of course, we may even consider mechanical ventilation. Now, the guidelines enlist all the different interventions that can be carried out, and I won't list them all, but it is important for example, immunization to take place as early as possible, even against the flu, for example. This is very important because it may lead to further respiratory problems. And of course, otherwise, pneumologists should be called upon, because when there's a loss of ambulation, then the respiratory problems get even more serious. A few more words about the heart. Well, we know that heart failure is too often not properly considered in DMD boys because physicians tend not to properly consider them, whereas we know that it is now a well-established approach, the one that aims at increasing these patients' survival. And here you see the timing for all the different tests that should be submitted to the patients for what pertains to the heart. ACE inhibitors may be used based on some studies that precisely orbit around the relevance of an early, timely treatment of this kind. And this has often paved the way to a better understanding, for example, of the mechanical functioning of the left ventricle in these boys. Sometimes, of course, defibrillators may turn helpful. And then the several bracings that can be used, sometimes during the night, sometimes just to prevent limb retractions. And we know that they are particularly relevant to dealing with the scoliosis, because maybe loss of ambulation takes place later, but scoliosis may occur all the same. Now, however, it seems to be less and less the case, even though when LOA takes place quite early, this may indeed occur, in which case there's a given curve, namely above 30 degrees, when the treatment should be started, the treatment with such several forms of bracing. And my last slides are about BMD. Actually, in the title of my presentation, BMD patients were also mentioned. So we don't have any well-structured guidelines here. Well, we know how variable in clinical terms BMD is, and therefore both in respiratory, cardiorespiratory and neuromuscular terms, we'll have to customize our approach. Anyway, we know that what is indicated for DMD patients may also apply to BMD patients, at least as a therapeutical option. And then, of course, we might want to know better about the genetic background of these boys, their family history, and so on and so forth. Well, heart diseases account for an important comorbidity and a possible cause of death in these patients. Hence, the relevance of primary prevention, ACE inhibitors treatment. And then we know, based on our experience with DMD patients, that such treatments are getting more and more often used also in BMD patients, but there are results to come up soon. And this is my last slide, and it is about the case manager's role to be played also within the framework of investigational drugs and experimental therapies more in general. Actually, you know, whenever a family get the diagnosis of DMD for their child, well, they are all ready to undergo any sacrifices in the world. They certainly want their child to get as well treated as possible. So the case manager shall inform the family about the therapeutic options, and of course they should also tell them about the aims of every single experiment, of every single investigational approaches, telling them about possible efficacy data, for example, or in case the study is in its very first stages, showing that there may be safety related problems. And then, of course, every everything should be customized once again. The case manager should understand what may best suit that particular family, that particular couple, or that particular boy. It may also depend on how far the family lives from the center where that particular therapy is administered. And these investigational products may give rise to various expectations, but this is also something that these case managers should work at. And that will be it. Thank you.
Thank you for this beautiful introduction and on DMD, but also BMD. Tomorrow we'll have a whole session on BMD, so please attend. And now we go on with Joan Donovan. She's the medical director of Catabasis. It's a pleasure for us to see you here. We wish to thank you as well as the Catabasis team, and you have participated, you have attended our conference for many years, and you have always given us updates. And the clinical development of Edasalonexant is over, but she's here to share with us the results collected up till now by this trial. You have the floor.
Buongiorno a tutti. Thank you very much for joining today, and a special thank you to Parent Project. My name is Joanne Donovan. I'm the Chief Medical Officer at Catabasis. I very much wish that we were coming together in Rome, and also that I had better results to share today. Before we get started reviewing the results, I'd like to express our deep gratitude to everyone who gave so much, really made
Scusami Joanne, scusami se ti interrompo, mi comunicano dalla regia che vediamo la...
We just see a portion of your screen. Yes, now it's better. Now it's better. Okay. We would see just a triangle of your screen.
Yes.
No,
okay.
no. Keep it like that.
Yeah.
Thank you.
So we are so appreciative to the Duchenne community for your support. Please note that this presentation is for those affected by Duchenne muscular dystrophy and their families and caregivers. Etasolonexant is an investigational drug that is not approved in any territory. Now, etasolonexant is an NF-kappa B inhibitor that was developed as an oral foundational therapy for all patients with Duchenne, regardless of mutation type. In the phase 2 study, etasolonexant showed evidence to suggest that it could substantially slow disease progression compared to an off-treatment control period. So we started a study, the phase 3 study, the Polaris DMD trial. Unfortunately, as has happened far too often in Duchenne, the trial of etasolonexant did not succeed in meeting the primary endpoint, which was the change from baseline in North Star ambulatory assessment over 1 year of etasolonexant treatment compared to placebo. Etasolonexant was observed to be safe and well tolerated in this trial, as we had seen previously. And after a thorough review of the results, we came to the unfortunate and difficult decision to stop activities related to development of etasolonexant, including the open label extension trial. Because of the contributions of the community and the investigators, we have learned a lot along the way, and I will try to share that. The Polaris trial was a 12-month randomized double-blind placebo-controlled trial where 2 boys received etasolonexant for each boy that received placebo. Boys enrolled were ages 4 to 7 up to their 8th birthday, any mutation type, and boys that had not been on steroids for at least 6 months. You just heard about the issues with steroids despite their very good benefits. And we believe that it is important to develop treatments to be able to spare those side effects of steroids. At the end of the 12 months, all boys had the option to enroll in the Galaxy open label extension. The endpoints were the North Star Ambulatory Assessment, age-appropriate timed function tests, as well as other measures of growth, bone, and cardiac health. The trial enrolled 131 boys at 37 sites across 8 countries, and only 9 boys didn't complete the trial, even through the pandemic. So we're very appreciative to everyone for their commitment. We don't think that the COVID-19 pandemic had an impact on the results of the trial. Of course, it had a major impact on how we conducted it. For this trial and for others, the visits that are made at that last time point, in this case 52 weeks, are very, very important to the trial. Since if we don't have that time point, we don't have information on results over the whole trial. Almost all of those visits happened during the pandemic, so everyone had to work very hard to get the information while keeping families and site personnel safe. About 15% of the visits were done in the patient's home by video, and we worked with Michelle Eagle and the Adam Group from Newcastle with regulatory input to get the best information we could. All of this was again due to extensive efforts by families and by sites to be able to get this done. For the primary endpoint, the change in North Star over 52 weeks, boys on etasolinexin unfortunately did not show a statistically significant improvement compared to those on baseline. The gray is placebo over time and the green is etasolinexin. While etasolinexin was slightly better at week 52, it was not statistically significant. And that p-value measures how certain we are whether a drug is better than placebo. The goal is a p-value of 0.05, which means that there is at least 95% certainty that the results are due to the drug. And that's what we need for regulatory approval. We also looked at 3 time function tests, rising from the floor, walking or running 10 meters, or climbing 4 stairs. The boys in the placebo group, now remember they are not on steroids, became slower on the speed of these tests over a year. The boys on the etasolinexin group also became slower, but were faster than those on placebo, but the differences were not statistically significant. We're working on analyzing the variability in these tests, as well as the individual tests in the North Star, to provide information to better design future studies in Duchenne. The PODCI is a questionnaire for parents about abilities in everyday life. For the basic mobility and transfer scale, which reflects muscle function, the scores for boys in both groups went down and the differences were not statistically significant. We did plan to look at how younger versus older boys in the trial were affected by etasolinexin. This shows the time to stand from supine on the ground, which was faster by 2 seconds for the younger boys on etasolinexin compared with the younger boys on placebo. But there was no difference for the older boys. Basically, while we were able to see that there were signs that etasolinexin had a positive effect, in speaking extensively with experts in Duchenne, we all came to the conclusion that it was not enough for regulatory authorities to look favorably on the results. Etasolinexin was well tolerated in the Polaris trial, as we'd seen before. Most adverse events were mild in nature, and there were no serious adverse events that were treatment related. The boys on etasolinexin grew similarly to boys not affected by Duchenne. We're still analyzing data on the heart rate of boys in the trial and its variability. And at week 52, we didn't see significant differences in the heart rate, but there are more data to analyze and share. Bone health was measured at the start of the trial before boys received study drug and after 52 weeks, which we are still analyzing. We did see that at the start of the trial, even before any treatment, including steroids, bone density was very low in these young boys and correlated with total muscle mass, which says that it is the disease process that is producing this low bone density rather than, for example, steroids. Several boys had vertebral fractures at the start of the trial, and this underlies how important bone health is in Duchenne. Based on the data, we made the very difficult decision to stop activities related to the development of etasolinexant, including the open label study. We immediately shared with families whether their sons were on placebo or etasolinexant, and the investigators were able to share individual data. We'll continue to analyze additional data, including the bone and cardiac, and we're committed to sharing that with the Duchenne community in presentations and scientific papers that are forthcoming, and to contribute to natural history databases. It's our sincere hope that research from the etasolinexant program will contribute significantly to the natural history of Duchenne and can be used to benefit Duchenne research today and in the future. Again, we'd like to thank all the boys and their families for their sacrifices in participating in our clinical trials, as well as all of their contributions to Duchenne research. We'd like to thank the patient groups, the investigators, the trial site staff, for all helping to understand as much as we could about Duchenne in these young boys. We're extremely grateful for all your efforts in executing this clinical trial, especially through a pandemic. The community support has been incredible, and we extend our deepest thanks. Molto grazie a tutti.
Grazie Joanne, passo la linea a
Thank
Gloria.
you very much, Joanne. And now the floor goes to Gloria for her to introduce us to our next speaker. Thanks a lot, Joanne. Thank you. Please stay with us until the end of this session for the Q&A time. And now it is my pleasure to give the floor to Eric Hoffman, who's Executive Director of ReveraGen Biopharma, and he also works as a professor at the State University of New York. And of course, we must recall at this stage that he is responsible for the discovery of the DMD protein. So now he's going to tell us about vamorolone, that is an analog of glucocorticoids. The aim is actually to mimic the action of glucocorticoids, thus limiting, reducing the side effects. Thanks, Eric, for being with us.
Sorry, I was muted. Thanks for the opportunity to speak to you this afternoon. I'll be speaking about vamorolone and some disclosures. We are not publicly traded, but we have a partnership with Santhera that is publicly traded. As you all know, there's DMD standards of care, which have become much more consistent over the last decade. And part of the standard of care is corticosteroid management. But with corticosteroids, they work quite well. They're strong drugs, and they are very potent in changing much of the transcription of your genome, and it ramps up genes. And with that, they suppress innate immunity danger signals. As Joanne just mentioned in the previous, NF-kappa B is a key target there. And so they're impressive anti-inflammatory medications. We know that DMD, as Joanne also mentioned, has a strong inflammatory component from birth. And we had shown that a fetus with Duchenne does not have much wrong with their muscle-accepting dystrophin, but soon after a Duchenne boy is born, these innate immunity inflammation happened quite strongly. So the goal is to suppress that and help muscle help itself in a way. With corticosteroids, while they have benefit, they also have lots of side effects. And these have been known since the 1940s, including increased risk for infection, osteoporosis, excessive hair growth, mood changes, appetite. And if you look on the FDA label for deflazacort DMD, these are all listed as known or potential safety. So if we look at the drugs of prednisone and deflazacort and how these are the actual drugs. So the drug here is in green, what prednisone looks like. And orange is deflazacort, you see how they bind to the receptor that carries out that activity, the glucocorticoid receptor. So they sort of, this is all the surrounding receptor and how it interacts with each of these drugs. And you can see that prednisone and deflazacort are nearly identical. You can see these interactions are very, very similar. Well, what we did with vamorolone is change this one site. So this one site, which you see here acting with the receptor in prednisone and deflazacort, we remove in vamorolone, and that twists the interaction of the drug with the receptor a bit. So what that does is it seems to retain efficacy. So you see here, these are DMD boys, 48 DMD boys treated over 6 months, or 24 weeks. And as we increase the dose of vamorolone, their improvement over 6 months increases. So we see a dose-dependent evidence of efficacy. And that was similar between all the outcome measures we looked at. We then went on in a recent study that followed those same 48 children over 1.5 years, or 18 months, and we saw that all the outcome measures continued to improve over 1.5 years. So here you see the p-value is all significant and all the changes consistently for every way we measure that. Now, if we compare that to placebo, here is not placebo, but an external comparator. So this is a natural history study of corticosteroid-naive children in a natural history study. Children at this young age are relatively stable, but you see with vamorolone, they all improve, where this is stable, and you can see they get improve with time with vamorolone. If we benchmark that to prednisone, now we don't have pre-post prednisone in the natural history studies, so this is cross-sectional, but we see that roughly the effect is similar to corticosteroids, although it's not a head-to-head comparison. So these are open label studies, not double-blind or placebo-controlled. We tested a broad dose range. It seems that 2 and 6 are the ones that seem to show the dose-dependent efficacy. We see that improvement over 6 months and continued improvement over 1.5 years, and it seems similar to corticosteroids. But what of safety and side effects? So this is from the deflazacort study from Griggs et al. That was used to get deflazacort approved for DMD in the US by the FDA. And you see one of the side effects is stunting of growth. And you see these negative numbers here. So almost basically all the patients on deflazacort show a slowing of their linear growth rates. And you also see a high degree of cushingoid, weight gain, excessive hair growth, and behavior change. If we look at vamorolone, again, these are not head-to-head studies, but open label, we see the kids are all actually growing a bit more. So none of them are showing stunting of growth. Also, if we look at cushingoid, weight gain, hirsutism, or behavior change, they all seem quite a bit less than what seems to be observed for corticosteroids. So in summary, we seem to see dose-dependent efficacy for DMD, but these are open label studies with external comparators. We seem to show less safety concerns of corticosteroids, no stunting of growth, normal bone biomarkers. We are currently just finishing a 120 patient blinded study, so that has both placebo and prednisone as comparators. And the last patient last visit for the 24-week period was just yesterday. So now all 121 have finished the 6-month period. And we should be able to look at the data of vamorolone versus placebo and the other arms in 2 to 3 months. We've also shown structure-activity relationships consistent with the clinical findings, where loss of transactivation is coupled to loss of safety concerns, but retaining or improving transrepression keeps that anti-inflammatory effect. We have seen that about 95% of families and physicians opted to remain on vamorolone rather than transition to corticosteroid standard of care. So this suggests patient and family satisfaction with vamorolone. We also have an extensive patient years of safety experience. So about 150 patient years on high dose vamorolone, and it seems to be quite safe. I'm just anticipating a few questions to end. Would vamorolone have potential efficacy in other chronic inflammatory diseases? Yes, we see promising preclinical studies in asthma, multiple sclerosis, inflammatory bowel disease, gliomas, and arthritis. Assuming approval in Duchenne from the FDA, what is the anticipated time period for that approval? Probably late next year. What about older and younger DMD boys, including those already treated with corticosteroids? We do have planned a clinical trial that would enroll a broad age range from 2 to 18 years, and that would include both steroid-treated and steroid non-treated. And we anticipate enrollment late this year. I thank Jesse's Journey for Canadians, support of Canadian sites, and the Duchenne UK has ring-fenced some funding for UK sites should our current blinded study prove successful. One last slide, who is running the vamorolone program. Santhera has exercised option for future sales and marketing in all indications, all countries. But ReVirogen, I serve as CEO, continues to manage and run clinical trials in protein. But we expect a transition from ReVirogen to Santhera over the next 12 months. We also have a trial planned for Becker muscular dystrophy with Elena Pegorato and Luca Bella's group in Padua. Great colleagues and friends, and with Paula Clemens in the University of Pittsburgh. So we're just assembling the final funding to kick that off. And we thank all the foundations that have helped support the vamorolone studies over the last 10 to 12 years, and it would not have been possible without both the EU government, US governments, and many nonprofit foundations that collaborated with us. Thank you.
Grazie mille Eric per la sua presentazione chiarissima.
Thank you, Eric, for your brilliant presentation and also for suggesting and answering the questions, and also for the good news about a trial on Becker in Italy. And now we give the floor to a new company. It is FibroGen. We are having them for the first time this year. And so we immediately give the floor to Bassem. Sorry, Bassem, I won't be repeating the surname because I'm sure I'd get it wrong. From the company FibroGen, their approach that aims at blocking fibrosis in the muscle. And more specifically, there is a clinical trial that has just started in non-ambulatory Duchenne patients. So it's a very interesting trial, and we are very glad to listen to you. You're welcome. You have the floor.
Thank you very much for PPMD and for inviting FibroGen. And on behalf of FibroGen, I would also wish, or next year, we meet live in Italy to discuss further the details of our phase 3 and where we stand as we speak. So without further ado, let's jump in the first slides. I'm going to share it now. So before we start, my name is Bassem Mankabadi. I'm a board certified surgeon here in the US. I'm leading the Duchenne muscular dystrophy program for FibroGen. I did my training back in New York at SUNY Downstate and then Brooklyn Hospital. Then I joined FibroGen, UCLA for a couple of years, then Amgen, and then here I am in FibroGen. So the agenda today, we were going to discuss in a nutshell the phase 2 results, which is a Mission DMD, the overall results of pamrevlumab. Our drug is a monoclonal antibody given intravenous bi-weekly. And then I'm going to talk briefly about the pamrevlumab development in DMD, and then I'll touch base on the 2 phase 3 trials that we are conducting as we speak. And then I'm going to conclude my presentation in 10 minutes. So phase 2, first, before I start, the full details of phase 2, we are planning to present them during the US PPMD. The conference will be in June. However, I'm going to give a brief summary of the outcome as we speak today, and then I'll move forward. Our phase 2, the Mission phase 2 trial, it's an open label trial for non-ambulatory patients with Duchenne. It's an open label, as I mentioned, and it has 22 patients enrolled to date. The enrollment is complete, and each subject received pamrevlumab 35 milligram for 2 weeks and every 2 weeks. And we have the data cut at 1 year and then another cut at the 2 years after receiving pamrevlumab. So the 2 years data, this is the one that I'm going to share right now. We have the preliminary data after 1 year. We shared already in the prior conferences. So the safety was the goal of our trial and the proof of concept. And we did measure a bunch of endpoints, mainly for the pulmonary function test using % predicted forced vital capacity, peak expiratory flow, and forced expiratory volume at 1 second. And also we look at the cardiac function in terms of the ejection fraction assessed by MRI, not an echo. We used an MRI. We looked at the fibrosis by late gadolinium enhancement. And we also evaluate the muscle in terms of...
Vado? Bassem, scusami, mi dicono dalla regia che non dovresti condividere le slide sul tuo schermo perché non si vedono.
We can't see the slides. We are not having screen sharing. It's not working. Okay, your screen sharing is not working.
All right. Now maybe now it will work. Share.
Scusaci, abbiamo avuto un momento di
confusione. Sorry, but we had to realize whether you didn't want to show us the screen or it was just that the screen was not being seen.
Oh, sorry, my bad. So now you can see the slides, correct?
Yeah.
Yes, now we can see the slides. Thank you.
Beautiful. So yeah, so
presentation mode if possible. Presentation mode if possible.
Okay, here we go. So this is the slide that I was talking about, our phase 2 trial, and I already touched base on the primary and secondary endpoint that we are evaluating as we speak. And then we had the screening done was for 4 weeks. We have a first analysis done after 1 year of pamrevlumab usage, and then another analysis done after 2 years of pamrevlumab infusion. And then all patients rolled over to an open label extension, which will be carried over for 4 years in addition until all the drug got approved. So either or. Our primary endpoint in the phase 2, the MESSION trial, was the annual change from baseline in forced vital capacity % predicted. And also the baseline the change from baseline into week 104 in forced expiratory volume at 1 second, peak expiratory flow, also ejection fraction change from baseline to week 104. And then we touch base on the performance of the upper limb as a second endpoint, grip strength and cardiac fibrosis and upper arm biceps. All these imaging endpoints were done by MRI. So in summary, the overall pamrevlumab showed promising results across the many endpoints, muscular, pulmonary, and cardiac function. And again, all these details will be shared in the US PPMD. Pamrevlumab improved muscle function as an important aspect for patients to improve their daily life and give them an ability for function independent. The performance of the upper limb showed scores declined less than pamrevlumab compared with the anticipated annual decline seen in historical published data. In addition, there is a correlation, positive correlation in terms of the reduction in the muscle fibrosis at week 50, at the 2 years cut in the biceps brachii in compared to the improvement of the muscle function itself, the performance of the upper limb. So the decline was in positive correlation, the less fibrotic, better performance of upper limb. And also the grip strength, we assessed it by handheld myometry. And that also showed an improvement in the grip strength compared to the natural history, the anticipated decline in the natural history in this population. In terms of the cardiac and pulmonary function, those are as you know, the most common cause of morbidity and mortality in this population. The respiratory function, the percent predicted forced vital capacity and the peak expiratory flow rate and the percent predicted forced expiratory volume at 1 second, all that declined, but less declined than the natural history. So there was slightly declined in 2 years cut, and but way better than the anticipated decline that we see in this population. In terms of the cardiac ejection fraction, we show stabilization and even slightly improved in ejection fraction compared to the natural decline annually in this ejection fraction. And this measurement done, as I mentioned, by MRI. Again, we looked at the correlation between the ejection fraction and the cardiac fibrosis, and we found that there is a positive correlation. That means less cardiac fibrosis in these population who receive pamrevlumab and better ejection fraction in those patients. In addition to that, we didn't even stop there. So we just looked at the global myocardial circumferential strain as a more robust endpoint to give us the better evaluation for the ejection fraction of the left ventricle. And we found exactly the same outcome like the ejection fraction itself. And so safety, in terms of safety, the 21 patients received, they were all non-ambulatory. We didn't see any surprises in terms of safety. The routine, the flu-like symptoms happened in this population. The side effect was headache, nasopharyngitis, vomiting, cough, pyrexia or fever, and back pain. There was no treatment emergent adverse event led to discontinuation of the treatment at all in this trial. And all these symptoms were mild and moderate per CTCAE guide. So that led us to the phase 3 trials. So once we had that results in phase 2, we decided to go ahead and start the phase 3 trials, which is called Lelantus studies. Lelantus 1, it's non-ambulatory trial. Lelantus 2 is the ambulatory trial. Before I jump in the phase 3 trial, we shared all these informations with the FDA in April 2019. And they received the information very positively, and they advised us to go ahead and start the phase 3 trials. In November 2019, we met with the EMA also, and also the same concept, that they received the results very positively, and they advised us to continue with evaluating pamrevlumab in phase 3 trials. And based on our meetings with them, pamrevlumab was designated as an orphan indication. And right now we started the phase 3 trials in both ambulatory and non-ambulatory trials. So globally, it will be a global study. And this is Lelantus 1, which is the non-ambulatory trial. It's a phase 3 randomized double-blinded trial of pamrevlumab or placebo in combination with systemic steroids or deflazacort in subjects who are non-ambulatory. The same dose, 35 milligram per kilogram IV, given bi-weekly, and then systemic steroids for SPO. Primary endpoint that we agreed upon with the health authorities in both EMA and FDA, as I mentioned earlier, was the change in the total score of performance of the upper limb using version 2.0 from baseline to week 52. And the secondary endpoints was the percent predicted forced vital capacity, peak expiratory flow rate, and also the grip strength by handheld myometry, and also the change in the cardiac ejection fraction used from baselines using MRI. The safety assessment, we're going to look at the treatment emergence adverse event, serious adverse event, and also the clinically significant any lab abnormalities, any hospitalization due to the two factors, cardiac or pulmonary causes. Expiratory endpoint, we have the Duchenne video assessment, and I see Casimir is presenting soon after my presentation. Those are video will be tasked, caregiver will take this video for this patient to evaluate the fine movement or the improvement or the decline in the function of these patients. It's an expiratory endpoint, and we are glad that we have these tools with us so we can have that quality of life assessment while we submit our file. MRI. So we decided to move the MRI, all the MRIs to the expiratory endpoint as well, based on the feedback that we received from the agency. So technically, once we met with them initially, they were in agreement actually with the MRI as a second endpoint. However, in the follow-up, they decided, hey, it's still biomarker. However, just put it as an expiratory endpoint for now. And then if it's positive result, we're going to promise that we're going to put it in the label. So we decided to go ahead with that approach, and we move them to the expiratory endpoint to evaluate better. And it will be the same style, the cardiac fibrosis, muscle fibrosis, and circumferential, myocardial circumferential strains. Okay, so in a nutshell, this is at 12 years of age and older, non-ambulatory patients, and the same, the pamrevlumab 35 milligram per kg, and bi-weekly, and also the matching placebo plus steroids in both arms. So the key point here that after 1 year of pamrevlumab infusion or the placebo infusion, patient will be rolled over to an open label extension, where they will be given pamrevlumab plus any standard of care plus any approved therapy. So if the patient is eligible for Exondys, Vyondys, or Viltepso, or any approved therapy, even the gene therapy that's coming hopefully soon, will be eligible to be in the OLE part of our trial. So technically, once the patient received our pamrevlumab, continue with the blinded phase, move into the OLE, they can get any approved therapy as an additional help for this population. Okay, so Lelantus-2 also, it's a phase 3 blinded, pamrevlumab plus placebo or placebo plus corticosteroids in same dose, 35 mg per kilogram bi-weekly. We are targeting 70 patients who are 6 to 12 years of age, less than 12 years of age. And patients will receive pamrevlumab in a blinded phase for 1 year, then followed by to roll over into the OLE with the same style. Any approved therapy will be given to them in addition to pamrevlumab in an open era. So our primary endpoint was based also on the discussion with the agency and also with the followed the FDA guidelines for Duchenne, which is the North Star changes from baseline to week 52, and bunch of other function endpoint, which is the 4-stair climb, 10-meter walk run test, and then time to stand, and then the loss of ambulation. Loss of ambulation was added based on the EMA feedback. So initially I did not propose this to the agency. However, the agency recommended to look at this loss of ambulation from baseline to week 52, which I agreed, and we agreed to add it as a second endpoint in our trial. Safety assessment will be the treatment emergence adverse event. Exploratory endpoint will be the Duchenne video assessment again, and then just one MRI for these patients, which is the vastus lateralis muscle for the lower extremities, assessed by MRI. In conclusion, the result from phase 2 was the backbone for our trial to move on, and for phase 3, for 2 trial for phase 3, and the phase 3 trials, the both Lelantus-1 and Lelantus-2, there will be the main aspect of in our filing for the efficacy of pamrevlumab suggests so far the inhibition of CTGF improved the structure of the function of the skeletal and respiratory and cardiac muscles, and reduce fibrosis burden associated with assessed by MRI across all parameters of this disease. To our knowledge, this is the first time for anti-fibrotic agent to show a potential slow disease progression in Duchenne muscular dystrophy, and overall the trial is promising so far in the phase 2, and the drug is well tolerated in this pediatric population and showed that promising results based on the compared to the natural history though, but we did not have the randomized trial. We are working on it as we speak. And that's it, and that's conclude my presentation, and thank you again PPMD and the committee for inviting FibroGen, and I'm glad that I spoke to you guys.
La parola a Gloria.
Grazie Fernanda. Grazie.
The floor now goes to Gloria. Yes, thank you very much. It is now our pleasure to give the floor to Dr. Paolo Bettica, Medical Director of the Italfarmaco Group, with a special page on DMD and BMD. He will be updating us about the clinical development of Givinostat. Actually, we did hear about that even last Wednesday about HDAC. Anyway, Paolo, you will have to go through the effects of Givinostat on DMD patients. And let me also remind you that tomorrow at 11:30, there will be the BMD dedicated session. So we'll keep talking about this as an IND for BMD. Thanks, Paolo. You have the floor. Thank you. Thank you very much. Thanks for the invitation. It is always a pleasure to be here with you, however virtual that may be this year, but it's still a very important moment. As Gloria has anticipated, I'm going to update you on Givinostat. Okay, now you can see my slides, I understand. So, this is my disclaimer. I work full-time at Italfarmaco. Givinostat is now being developed for DMD and BMD, but so far it has not been approved for marketing anywhere else, including Italy. Therefore, this presentation mainly aims at spreading and discussing scientific data. So what I'm going to do in the time allotted to me is to talk about the role of this product in DMD. I'm also going to update you about the recent use of this drug in, well, mainly the most recent data of this drug being administered to DMD boys for the last 7 years. And then I'll be talking to you about some pipeline studies. As I'm sure you know by now, the absence of dystrophin in DMD boys' muscles entails that muscular fibers may get impaired much more often than not. And this also goes with a deficit in all repair mechanisms. So we both get more frequent lesions and less frequent repair. As a matter of fact, we only get scars that are not supposed to replace the muscle, of course. Givinostat precisely acts upon such repair mechanisms, so it cannot regenerate dystrophin, but it can act on such repair mechanisms, thus reducing the muscular fiber necrosis and the derived inflammation, as well as other processes, for example, flap replacement. But it increases and improves the regeneration on the other hand. Now, these are conclusions that we achieved based on our preclinical trial results, but more importantly, based on the biopsies we got from the boys on the phase 2 clinical trial, whose results were published a couple of years ago. So here is a recap of what we currently know about Givinostat. So, as I said, the preclinical DMD model already showed that the product can prevent the muscular damage expected, and this goes with a better performance as seen during the treadmill test. Then the results were confirmed in those boys who were included in the phase 2 trial, as I have already said. They underwent a biopsy before treatment and 1 year after Givinostat treatment. So histology showed an increase in the diameter of muscular fibers and a decrease in the tissue damage. And the data were furtherly confirmed with the NMR. Well, at that time, we just used a quantitative RM, but we could certainly see that there was a decrease in the muscular damage progression. And then, considering that we have developed givinostat for several indications, so far we have collected the safety and tolerability data for over 500 subjects. Therefore, we can definitely at least say which are the most frequently occurring side effects are, namely reduction in the number of platelets and some diarrhea. However, these side effects can both be dealt with either by reducing the dosage or by discontinuing the treatment if necessary. So we have learned, if you wish, how to manage these problems, at least these two problems. Now, here are some data about the boys, now young adults, included in the phase 2 trial and who have been on this treatment, first in an extension study and now in the long-term study. So these data show what happens after over 7 years of treatment, as for example, to the disease milestones. What can we see here? Well, LOA, first and foremost, loss of ambulation. Of course, the Synergy group has already published some data showing that the average age at which LOA takes place further, however, to steroid treatments is 13.4 years. On the right-hand side of the slide,
non ci riesco, vabbè. Comunque sul lato destro della
on
slide.
the right-hand side of the slide, you can see the graph regarding the boys on givinostat. Here, as you can see, the average age for LOA is 16 years. So that seems to suggest that at least for 2.5 years, the boys keep their ambulation ability. Now we're also trying to understand whether givinostat is also effective on other parameters that are as important, namely the respiratory parameters. Here again, we can consider the data on the boys' natural history. And we know from this data that especially from 10 years of age upward, there's an almost 6% decline every year in terms of FVC, the forced vital capacity, which says, the degree to which lungs get filled with air, as well as the peak, the PF, sorry, the PF, the peak expiratory forced peak, expiratory peak. And here you see that we actually get some improvements. We seem to have either no decline at all or a decline that is more than half than the one that we were aware aware of. Okay, having said that, what about the studies now ongoing? So this is the EPIDIS study. It's a phase 3 study, hopefully leading us to drug registration. So it's a double-blind study. There's, placebo for 1 boy and givinostat for 2 boys. This is the ratio. Treatment is administered for 18 months with 3 RMs, all for the whole length, and several physical examinations, which take place more often at the beginning, especially during the first 7 months, in order to adjust the dosing, and then less often. However, every 3 months, all functional tests are carried out. You've already heard about that, the 4 steps, the North Star, the 6 minutes walking test, and so on and so forth. So respiration is seen at baseline, and then at the end, after 18 months, and another magnetic resonance is carried out. So at the end of the treatment, that is at the end of these 18 months, the patients can be moved to the open label study, where they will all be on givinostat. So about this study, the EPIDIS study, you might remember that a few months ago we told you that the study had been declared as non-futile, thus allowing us to keep, of course, going with it. But more than that, we also considered the kind of patients that should be enrolled in the study, and this has been viewed from a different approach, the approach of variability. So 169 were supposed to be enrolled. Actually, the number is slightly higher. Now there are 179 patients. Around the month of June 2022, we'll probably have the results, further to which the registration file will be circulated both in Europe and in the US. And this is the open label study design. So the patients already included in the givinostat studies can have access to an open label study. And here you see what it entails. Physical examinations are more frequent at the beginning, and then every 4 months. The primary aim is to consider long-term safety, but other measures will be considered, namely regarding function tests, considering the patient's age and ambulation condition. Something else about how clinical trials have been managed in this pandemic time. Now, up until today, we have had no, the pandemic of COVID-19 has not undermined our studies. Of course, we have used some procedures to allow our patients to keep being treated, of course, in perfectly safe conditions. And of course, we also wanted to, keep the scientific goodness of these studies, which is crucial, because if we can't show this, if we can't come up with robust data, well, we will have thrown it all, down the gutter. So we have tried to do our best. Sometimes we have had to delay the time of some examinations, but especially for the intermediate examinations, well, we have moved them into home examinations. So we didn't ask the patients to come to the center, but we did go to see them at home. Now, this is something that is very dear to us, because we can understand how difficult it can be for families to take their children, their boys, to our centers. However, especially for the last examination, one of the most important ones, of course, well, families shall have to bring us their children, because this is something that cannot be done at home. It is, again, of paramount importance for our study to be considered as perfectly compliant with what the regulatory agencies expect. As for BMD, I'm sorry, Adele, I'm afraid I will not do what you thought I would do. In other words, I cannot come up with actual data about this. Anyway, this is a phase 2 study, a double-blind one. Randomization was again 2 to 1. And the primary aim here was the morphological examination of the muscle. We wanted to see whether in this population the muscle morphology also changed through, of course, the biopsy, and also through the RMI. And then the various functional tests were also carried out. So here you see the number of patients that were enrolled. 70 was screened, 71, 51 were enrolled. We believe next June we'll be able to come up with the data. To conclude, I wish to thank you all. I would like to thank the families who have participated and are still participating in our Givinostat efforts, and of course the sponsoring companies and associations. Thank you.
Grazie Paolo, grazie per questa interessante presentazione su tutti i risultati fino ad oggi disponibili con gli studi clinici con Givinostat.
Thank you for all the results. And now we give the floor to Michela Aguglieri. She's a neurologist, an Italian neurologist who works in Newcastle in one of the most important centers for the care of DMD and BMD in the UK. And Michela, apart from being a neurologist, also a scientist, and she's the most important reference person for the 4DMD study, and that trial aimed at comparing 3 different administration strategies for corticosteroids, prednisone, and the Deflazacort. And so we wish to thank Michela Aguglieri for being here with us, and so I give her the floor to tell us about the study. Thank you, Fernanda. Thank you for inviting me and participate in this conference that is very close to my heart, especially being an Italian living abroad. I have lived abroad for 15 years, so I apologize for the things I might get wrong in Italian, but I believe that being the conference essentially held in Italy, I still prefer to speak Italian, even if with some mistakes. I've been working in Newcastle and I have contributed in the 4DMD study as medical coordinator, so managing the medical part. The 4DMD study is a study that many of you have heard about. This study has been with us for many years. It was started in 2013 with the screening, and so I'm very glad today to share with you the first data. These are still not the results, but I do hope that these results will be there soon. I'm sharing my screen. Yes. These are my disclosures. As an introduction, for DMD is a multi-center involving a number of centers in 5 different countries. And as Fernanda mentioned, the objective of 4DMD was comparing the 3 regime of corticosteroids that are more normally administered in DMD in terms of benefit on muscle strength and muscle function, and also their side effects. The 3 therapies that were compared: prednisone, daily administration of prednisone, intermittent prednisone, so 10 days in, 10 days on, 10 days off, and deflazacort administered daily at the doses recommended in the literature. Of course, the study was designed many years ago, and these were certainly the regimes that were normally prescribed. Other dosages were developed in future years, but I mean, these different dosing plans are not included here. Age between 4 and 8, so they had to be younger than 8 at the moment of enrollment, and they had to have a confirmed diagnosis of DMD, a genetically confirmed DMD. And the other essential criterion was that they had to be steroid naive. So these are children that are absolutely steroid naive, or for a period less than 4 weeks, and not for DMD. The study design had as primary outcome the assessment of the effects at 3 years, but we went on with our follow-up up to the age of 5. At least for the children that were enrolled first. So the study was designed according to the standards of care. The study started in 2013, so the standard of care was that of 2010. The children had to be followed according to the existing guidelines. The primary outcome measures in order to assess the positive effect on muscle strength. Well, there are 3 variables: time to rise from the floor, the TT stand, then force vital capacity, FVC, as mentioned by Paolo, that is the measurement of the respiratory flow, and then the treatment satisfaction questionnaire. This is a questionnaire assessing the impact as benefit and side effects as perceived by the family. Then there are secondary outcome measures, tolerability. So how many children were able to start and complete the trial with the same corticosteroid at the same dose, then adverse events and a number of other functional outcome measures, North Star, time to run 10 meters, and the 6-minute walking test. Then there are measurements for quality of life and cardiac function with ECG and echocardiogram. The specificity is that we developed standardized protocols for the management of predictable steroid-associated side effects. This is a unique feature of this trial, of this study. So this is different from clinical practice. And it has also been the most difficult component because in fact, there are no standardized guidelines as to manage, I don't know, weight gain or behavioral changes. And the side effects that were considered as of special interest was, of course, weight gain, behavior changes, and the impact of steroids on bone health. Today, what I'd like to share with you was essentially the baseline data. So the description of the Duchenne population before starting steroids. And these findings, these figures are not published in large studies, and they are still provisional, but the study has been completed. It was completed in 32 sites across 5 countries, US, Canada, UK, Italy, and Germany. 196 boys were recruited and monitored for 3 years. So the study is completed, the database has been closed, and now we are examining the data. Next week, the results will be discussed with the group that designed the study, and we hope we can have the possibility of publishing the results and make these results known to the world by May, June this year. So in 2021, the results of the 4DMD study will be made known. They will have an impact on the care of the children with DMD all over the world, because until, for the time being, corticosteroid is the baseline treatment until we prove something to the contrary. As we said, 196 boys, average age 5.8 years. This is subdivision by country. You see the higher number is in the US, and then UK, and then Italy, and then Germany, and then Canada. Most subjects per group of ages were between 5 and 6, followed by 6 and 7, and then 4 to 5. And this mirrors the clinical practice for steroids that usually are prescribed between 5 and 7. But there is also a good group of children that were treated earlier on, so around the age of 4 or much later. And we hope they can give further information as to the ideal time to use steroids. All the children were characterized from the genetic viewpoint. The most frequent mutations were out of frame deletions, as expected. They accounted for 67% of all mutations. Out of the 68%, 67% was made up of potentially of mutations that might be eligible for exon skipping, with a number of exons involved, 19% for 51 exon skipping, followed by 53 and 45 exon skipping. The mutations, the nonsense mutation, the stop codon mutations are a certain percentage. So in fact, our population is in line with larger DMD casuistics series. So then the frequency of mothers who were carriers of the mutation of the dystrophin gene. So in line with what has been reported already, some 2/3 were the mothers. For 2/3 of cases, the mothers were carriers. There was no big difference, though. Children who had a non-stop mutation have a higher likelihood of having a mother who is a carrier of the same mutation as against kids who had a different mutation or a duplication. Another important point is that in the United States, we had a high percentage where the information on the state of the mother, carrier or non-carrier, was unknown in 50% of cases. Maybe they are not tested as much in the United States, or maybe the children were followed in a different center and so the information was not available, but that is something that would deserve further attention maybe. As for clinical presentation, well, the average age, I mean, when parents for the first time start being concerned on their kids' development, well, the average age was 2.5 years, a range between 1 year and 3 years. 3.5 years. These are the concerns that are reported by parents. A general delay in development. So these children start walking slightly later. But it's also important to underline that only 26% of children have walked after 18 months. 18 months usually is considered as the cutoff for speaking of a delay in ambulation. So this is not such a typical feature of DMD. It's more of something that has to do with a general motor development, not so much with walking. And let's see, when the diagnosis is given in the different countries, we consider the global population, the average age at diagnosis was 4.5, but with a range that went as high up as 6 years. So there were children who had not been diagnosed till the age of 6. So the average delay between parents' concern and diagnosis is about 2 years, and in some cases even 3 years. So a very long lapse of time, and of course that is extremely stressful for the family. And Germany has a diagnosis age that is earlier vis-a-vis other countries, both, and the maximum difference is precisely in genetic diagnosis after parents' concern. So there is a higher awareness of the possibility of muscular problems in the children. So this is something else that maybe is worth further investigation. Another aspect is the growth of children with DMD before starting steroids. We know that steroids have a big impact both on body weight and height of the children. It is one of the, the weight gain is a problem, but also the stunted growth. And here we see that they are small children even before starting steroids. They have a general distribution around the 30th centile between age 4 and age 8, whereas for the weight, they are more, let's say, in line with the general population, so 40th percentile. As for function, Still we are studying all that, but as from the age of 4, these kids are different from children without DMD. But between age 4 and age 5, there is a sort of maturation process. If we see the functional scales between age 4 and age 5, well, children age 5 have better assessment if compared to those who are 4, whereas children who are 7 start having a decline in their motor function. Of course, these are not the longitudinal studies. These children have been just evaluated at that specific age. Other aspects, again, on this population before steroids, so steroid naive subjects, the use of splinters for ankle contractions. They are recommended in 50% of patients. So ankle bracing, but the percentage of those following the prescription is only 54%. But in general, all the countries who participated in this study, well, ankle bracing were or AFOs were more present in the United States than in other countries. Then there is another aspect here, language development. And that is confirmed in children that have a mutation at the end of the gene. Here we are considering also data on quality of life before steroids and motor function in young children with DMD before they start steroids, both as they appear, but also how in what way they are different from children who are of the same age group but without muscle problems. Well, of course, we all want to have the final results of the study. I do hope we can publish those results in the by June this year. And of course, I personally and the whole team will do our best so that those results are made known to the families. I'm not going into the details, but this is a list of other aspects of DMD that we'd like to consider using the information collected in the 4DMD study. For example, understanding the response to the steroid in the first 12, 18 months. So what is the effect of the steroid on muscle function at the very beginning of treatment? And this is very important, for example, to assess drugs such as abiraterone or critically assessing other therapies such as gene therapy, but also other aspects such as bone, effect on the bone, on growth, on heart function, on genotyping, phenotyping correlations. But something else I'd like to underline, the 4DMD study was really developed with the idea of trying to answer a number of standing questions on DMD. So really data are there to be studied. And we always open the discussion because anyone who is interested in specific aspects, please ask us questions and we'll be delighted to look at the data, trying to answer such questions by looking at our data, questions both for clinicians and parents. I mean, so just as many questions as possible as far as our data can help answer them. A big thank to the families, the children who have participated in this very long study. And the study was not so interesting as maybe today are gene therapies, but still they believed in the importance of collecting such data. All the sites that were with us for the last 10 years. And here, thanks to Robert Berg-Briggs, Kate Bushby, and Michael Eagle, who have contributed to this study. Thank you.
Grazie mille. Michela, cedo la parola a Gloria, che è collegata per introdurre il prossimo oratore.
Grazie alla dottoressa Guglieri.
Thank you, Gloria. Thank you very much, Dr. Guglieri. That was a very, very clear presentation, and it is now our pleasure to have here Mindy Leffler. She is the founder of Casimir, that was set up in 2016, further to the approval of eteplirsen. So everything started when the community realized no evaluation measurements had been detected for this kind of patients. So Mindy, you have the floor. Thank you very much for being here with us.
Thank you so much for giving me the opportunity. Let me get my slide deck. Sorry, the Zoom bar is covering up my ability to go full screen with the slide deck.
Mindy, facci sapere se vogliamo...
Mindy, please let us know if you need help, or maybe if you need some more time, because in that case, we can start with the Q&A session and then we'll come back to you.
Yeah, I'm sorry, just one second. The Zoom taskbar is frozen, so it's not allowing me to select full screen share, and it's not allowing me to move my slide deck forward at all. So if you want to give me a minute to troubleshoot that, you can...
Ok, possiamo iniziare magari ponendo la prima domanda, se la regia mi manda la prima domanda.
But we can therefore start with our first question, right? So that Mindy takes her time. Would that be okay? All right, so we have a question for Bassem. What about a reduction in fibrosis, and what about the data publication regarding pamrevlumab, regarding the phase 2 study? We can't hear you.
Okay, so yeah, I got the questions, and I believe, as I mentioned in my presentation, there was a positive correlation in terms of the reduction of the cardiac fibrosis in addition to the muscle fibrosis assessed by MRI and late gadolinium enhancement for the cardiac and the improvement of each function. I mean, what I meant by each function of these parameters are the cardiac ejection fraction and the performance of the upper limb in addition to the grip strength by handheld myometry. In terms of the publication, we are planning to publish the data I believe by the second or the third quarter of this year. We are working on the publication as we speak now.
Grazie mille. Chiediamo a Mindy.
Thank you. Mindy, are you okay? Yes, you seem to be okay.
Yes, it looks like it.
Please put it in a full screen mode. Right, okay, you have the floor, Mindy.
It should be now. Okay, thanks so much. Apologies for that. And thank you for giving me the time to present. I am actually the parent of a 17-year-old now with Duchenne. He has participated in quite a few clinical trials and has performed a number of different outcome measures along the way that he felt didn't really link to what he did in his daily life. So when he started his third clinical trial, we put the things that he struggled with on video. And we ended up capturing this sequence of his performance throughout the study. So this is his performance getting into our car at baseline of the study. And this is what he looked like 5 months into the study. And this is what he looked like 7 months into the study. And so for us, this was quite meaningful because this was something that we watched him do every day. And it was something that meant a lot to him because it was embarrassing to be lifted into the car by his parents. And what this helped us realize at Casimir was that, you know, Duchenne is really a disease where it becomes harder and harder to move until you were unable to move. And so we got the idea to look at ease of movement as a concept of interest in Duchenne, something that we can measure, because it really is at the heart of the disease, the boy's ability to move. So we thought, what if we could actually quantify how easy it is for these boys to move and look at that as a way to measure whether treatments are working or not. So the goal was really, we wanted to make sure that we could do that in a way that was sensitive. So looking at the different shifts in the way that the boys move over a relatively short duration of time. We wanted to look at it in ways that were meaningful to the boys. So what changes in the ways that the boys move are actually meaningful, meaning that they indicate a degree of disease progression. And we wanted to do it in a way that was reliable so that different people who were assessing with our methods and assessing at different time points would come out with the same numbers. So even prior to COVID, we were really advocating to look at boys' performance at home because there are a lot of ways that travel can interfere with their performance. In the United States, this is really a big deal because a lot of patients are flying really long distances to get to clinic, which affects the way that they perform. So even prior to COVID, there were reasons for taking a look at how the boys were performing at home. So this is the way the outcome measure works that we've designed. So a sponsor can look at the list of tasks that are really kind of daily activities that these boys perform, and they can choose which ones are applicable to the boys that are participating in their individual study. And then the caregivers, the parents, download an app from Google Play or the App Store. And then within that app, they can watch training videos that show you how to take your own videos at home. Then you take videos of your children just performing daily tasks in the home environment. And then we have a quality staff that checks the videos as they come in to make sure that they're done properly and send any back that have any problems. And then we have physical therapists that are certified as raters. They're trained on how to quantify our scorecards. And those central raters can quantify the videos and the boys' movements on the videos that come in. And then what we look at is the change over time for the individual patients. And what that allows us to do is just look at how every individual patient's performance is being altered rather than just comparing the treatment group to the placebo group in a more general way. So this is the list of daily tasks. So rather than kind of coming up with a task that we think might be relevant to the boys' lives, we just actually take a look at the activities that they do in their daily lives and quantify those. And these tasks span from kind of the younger, stronger boys to boys that are more progressed. And so each individual family would probably take only 4 to 5 of these videos. They would not take the entire list. So there's a subset that are applicable to different groups of boys. So this is an example of how this works. These videos were taken 30 weeks apart. This is a boy standing up from a sitting position. We use that rather than supine for the most part, just because it's a very functional position. Boys spend a lot of time sitting on the floor. And as you're watching these videos, just try to ask yourself, the difference between the two timelines, would you think that it is stable, that this boy is getting weaker, that this boy is getting stronger? So this is the baseline, getting off the floor. And this is 30 weeks later. So even the non-experts that we ask are able to identify that it is getting slightly harder for him to get off the floor at the second time point. And this is how it quantifies out on our scorecards. So the difference is, if you look at how far apart his feet are as he gets off the floor, there's a much more narrow base of support at the first time point. At the second time point, his feet are much further apart. And I think a lot of you as parents whose boys have been through this can identify that as it gets harder and harder for them to get off the floor, you see those feet get wider and wider as they get off the floor. And then the next change that you saw in this video is that in the first time point, he does not take his hands and put them in different places before he lifts his torso. And at the second time point, he has to get his hands close to his feet before he lifts his torso. That's because he's getting a little weaker in his trunk strength. And then lastly, in the first time point, he does not push his hands off his thighs to be able to raise that torso. And at the second time point, he pushes one hand off the thigh. So what we're looking at is what is the percentage of compensations that this boy is displaying at one time point? And what is the change in that, we call it severity percentage, between one time point to the next? So this young man has gone from a 25% severity to a 63% severity over this 30-week period of time, which is a relatively short period of time in the context of a clinical trial. So there's a lot of work to be done in developing an outcome measure like this. For us, what was most important was looking at reliability. So we want to make sure that different physical therapists score the same way on our scorecards. So that's inter-rater reliability. And we also wanted to take a look at intra-rater reliability. So does the same physical therapist score it the same way if they came back and did it later on? So this is just an example of the data that we were able to achieve on our intra-rater reliability. So this is the different physical therapists. Do they all score in the same way? The closer these numbers are to 1.0, the better the reliability. So as you can see, most of our tasks are up above 0.90, which is excellent reliability. So for us, this was great news. Anytime you're looking at greater sensitivity, you run the risk of not having people agree on the way that things are scored. So this was really reassuring to us. Same type of scores for intra-rater reliability. So does the same physical therapist rate the videos the same way when they look at them twice? So equally high reliability, close to 1.0 on a lot of these tasks. We also had a clinician who was an expert in Duchenne take the boys and put them in groups of how severe their weakness was. And then we took a look at whether our severity percentages kind of aligned with the groups. So did the severity percentages get worse as the weakness groups got worse? And what's important to see in this slide is you see these stair steps moving up. And what that shows is that the range of severity percentages aligned with the way that she classified how weak the boys were. So that just shows that the scale is working the way that we hoped that it would in these different activities. So really our goal moving forward in more recent work is to take a look specifically at these 4 to 6-year-olds, to take a look at those maturational pieces that were mentioned in the previous presentation is so important. So we want to make sure that we're modifying our scorecards to be as applicable as possible to this younger cohort because we feel pretty confident in the work that we've done with the older boys. So making some adjustments, we've actually eliminated the task of going from a laying down position to a sitting up position, because we just saw that so many boys that were in our healthy cohort of our study sit up in a compensated way when they're that age. You know, just healthy boys between the ages of 4 to 6 have some weakness in their tummy. They have trouble doing sit-ups. And so it was just very difficult to separate out the boys with Duchenne from the healthy boys in that age group. And then we also just took a look at different compensations and the way that 4 to 6-year-olds perform those compensations and how we could separate that out. So here's an example of what I'm speaking about. We originally had in our standing from sitting this half kneel position as the first compensation on our scorecard. And then when we took a closer look at that, we figured out that there's a way to separate out these healthy 4 to 6-year-olds from the boys with Duchenne, and that the healthy 4 to 6-year-olds, they stand up kneeling, as you'll see with this young man. But the boys with Duchenne do what we call tripod position, which is like almost a full Gower, but not quite. So they have one hand and 2 feet. And the older boys show that same pattern as well. So we're doing modifications to the scorecards to make sure that they're as applicable as possible to this 4 to 6-year-old cohort. And so just moving forward, at this point, we are live in a number of clinical trials, as I mentioned in the FibroGen study. So those of you who have children who are participating in that will get a chance to interact with us at Casimir and hopefully participate in taking these videos. We're going to collect additional data that will allow us to hopefully function as a main outcome or a primary outcome rather than a secondary or exploratory outcome. We're going to launch a study that will allow us to capture that data that will be worldwide. It will be something that your families can participate in remotely from your home without ever traveling to a center. So hopefully, if you're interested, we'll be able to get to know some of you through that participation. And then we're working towards regulatory qualification. We're in the qualification pathway at FDA and are hopefully working with our great colleagues at Parent Project Italy to start that effort on the EMA side. and have been surrounded by a number of groups that have been incredibly helpful in the development of this process that we're very grateful to, including these logos on the last slide. So thank you very much for giving me an opportunity to show you what we're working on. We feel very hopeful that this will be a way of looking at disease progression in a way that's meaningful to families and the boys and really reflects their function in their day-to-day lives in their homes. Thank you.
Grazie Mindy, grazie moltissimo per questa
Thank you,
bellissima...
Mindy, for this beautiful presentation. And now back to Gloria to go back to the Q&A session that we had just started. The next question. It is a question for Dr. D'Amico. Thank you, Dr. D'Amico, for being here with us. It is a question by a mother. The mother's name is Chiara. Chiara, well, please attend also tomorrow, because tomorrow you'll have Dr. Adorisio again from the Bambino Gesù, but we're asking the question to Adele now. To prevent dilative cardiomyopathy, it is better to have ACE inhibitors or beta blockers. Is it possible? What is in the literature? Well, good evening. Well, ACE inhibitor and beta blockers have two different effects. The ACE inhibitor is a therapy that remodels the heart wall, and normally it is indicated for primary prevention. Sometimes there is an indication to integrate that with beta blockers in patients who have an increased heart rate, to reduce heart rate, so not to overload the heart. So in primary prevention, usually we have ACE inhibitors as maybe you should ask this question to the cardiologist who's going to be here tomorrow. She'll be certainly more precise in her answer. Then we have another question by Alberto, again to Dr. D'Amico. An early start with cortisone, even without many symptoms or very minor symptoms, is always linked to a prolongation of ambulation, or is it better to postpone the beginning of this therapy? Well, cortisone must be done when the child has a sort of plateau. We know that the boys, as Michela said, from baseline data of natural history, they have a general motor delay, but which means that they acquire some skills later. When the child completes the normal acquisitions and then he reaches a sort of plateau stage, then we introduce cortisone. Why we shouldn't use cortisone early? Because the effects are due to the, to the doses that go on for years. There is no equation. The sooner you start, the longer the child will walk. Is not the case. And the loss of ambulation, the age when the child loses ambulation, well, that depends upon a variety of factors. We know that cortisone delays this moment, but there are also some genetic and epigenetic factors that lead to different ages when the child is no longer able to walk. Next question, Fernanda, for Dr. D'Amico again. At what age can we use this night splinters? Well, there is no precise age when should be introduced when the child has a good ankle range. It depends also on the compliance of parents and children. Well, it is better to have this ankle bracing at 3 or 4 years of age, because it's easier for the child to accept it when he's young. But there is no precise age, let's say between age 3 and 4. I don't know whether Michela agrees with me on that. I agree. I agree. There is a clinical indication, but also sort of behavioral indication. Usually children who are 3 or 4 do not really require ankle bracing to control the contracture. But if we wait, then it is more difficult to convince the child to wear it. So it is rather a matter of assessment, not so much of age. So the problem is not so much one of controlling the contracture of the ankle, but it's rather, I mean, to get him used to wearing it rather than an immediate need. Then there is a question by Walter for Paolo Bettica. Corticosteroids. Can corticosteroids interfere with the effects of givinostat? Well, we have studied the possible interference between corticosteroids and givinostat in animals, and the answer is no. The pharmacokinetics and the concentrations of the two drugs do not change. And all that we did in clinical trials are always as an addition to steroids, but we haven't tried givinostat alone in men. But for the time being, well, no, there is no evidence that this can happen. A question from Angelo to Eric Hoffman. The timing of a possible approval of vamorolone if all the expectations of the trials were satisfied?
So in the United States, the approval is expected next year. For EMA, it would probably be 6 months later because EMA wants to see longer term data. But that, again, as was pointed out, assuming everything goes very well.
Scusate, mi avvisano dalla regia che non abbiamo...
Sorry, we don't have much time, so we won't have enough time to ask all the questions and get answers. So we apologize. Sorry if we're not able to read all of them. Certainly we'll let you have an answer. We'll be sending emails to the different speakers. I go on till they tell me I have to stop. There is a question by Stefano. It is again on vamorolone. Of course, we wish that you are successful and that you can get the approval. Is there a shift to vamorolone? So what are the times for reducing the dosage of corticosteroids or a washout time, anything like that? The question is again for Eric.
So in our ongoing trial of 121 boys, 30 of them are transitioning from 6 months on prednisone to vamorolone, and that's done in a blinded manner. So we don't know which subjects are transitioning, but we'll know that data soon. So there we have a tapering of prednisone over about 3 to 4 weeks, and then we start vamorolone. The tapering of prednisone is quite controversial. There's not much evidence in any disease for the best tapering method. So I think that will need further study in the future, which we plan with a broader age range in older patients.
Grazie, Eric. Gloria?
Thank you, Gloria. Eric, another question for Paolo Bettica. There is a father who wants to know if you have published data on NMR phase 1 and if you carried out new NMR before and during treatment for the other phases, since there is a diagnostic tool that can guarantee a qualitative analysis of the muscle, and certainly that was used in phase 1. What did the data tell us? Well, the results of NMR were submitted during an MRI meeting when we still were able to travel around, so in 2019. And at present, we are working on a paper that will be published soon. As for NMR in other studies, the phase 3 study includes NMRs carried out at baseline, at 12 months and at 18 months. And there we'll have an assessment of NMR in a clinical trial in 120 boys. And so there we'll apply the protocol for quantitative measurement to evaluate the contraction in the muscle. For Paul again, and we hope to have what is the age you would advise for starting Givinostat, hoping it is approved? Well, a multifaceted answer to be correct. As for a mechanism of action of the drug, it could be started as early as possible. This having been said, we must also take into account something else. Hopefully, when we go and discuss this with FDA and EMA, when we'll discuss a possible indication, so with the regulatory authorities, we'll discuss with them what is the population of DMD that can be treated with this drug. So it is the labeling of the drug. And there we report the indications that will be agreed with the regulatory authorities. And FDA usually has a wider, so a more open outlook, whereas EMA possibly will say the ages that of the children that were included in the clinical studies, and at present it means over age 6. Thank you. Another question for Eric Hoffman and Basson. Well, when can we have a Duchenne trial for the two drugs, vamorolone and pamrevlumab, in Italy? Eric, you start.
I think that everybody on the panel envisions that the most effective therapies will be combination therapies between different drugs, even with gene therapy and exon skipping, because those are only abnormal dystrophin, not normal dystrophin. So even with dystrophin replacements, it's anticipated that additional drugs will be used in combination. So for us, we are a replacement potentially for corticosteroids, so we would not be used together. That speaks to the mechanism of action. So you'd combine drugs that should have complementary additional mechanisms of action, but would not combine drugs that have the same mechanism of action. So for example, it would probably be hard to combine gene therapy and exon skipping because they have similar dystrophin replacement mechanism of action. I think how that will play out is you need drugs that are approved. So for example, if we are fortunate and vamorolone is approved next year, it may replace gradually corticosteroids. So then other drugs become an add-on to vamorolone as they are currently an add-on to corticosteroids. But that will take time to figure out and discussions with regulators. So that's a long answer to what is a complicated question.
Yeah, I would agree actually with Eric. Here's Basson from Fibrogen. Nice said, and I believe I'm in agreement. It's tough and needs more discussion. However, in our OLE phase of our trial, we allowed any approved therapy, like Eric mentioned. So any approved therapy will be added to pamrevlumab during the OLE phase until the drug got approved.
Grazie. E credo che abbiamo finito così.
Well, one last question. One last question. We have time for one final question. Have you found differences within prednisone and fibrazzolone as to side effects on eyesight? Sorry, one of the side effects of steroids. The assessment of eyes was part of our protocol, but we still haven't got the data. These are within, these will be given when the results are published. I hope we can give those results by June. This is an aspect that will be taken into account at age 3. There is a limitation for the study for DMD. Prednisone given daily intermittent or deflazacort at 3 years, and we'll have a smaller group at 5 years. In literature, as far as we know, there is a higher risk of cataract in children treated with deflazacort if compared to prednisone. Thank you, Michaela. Gloria, one final question. Is not really a question, it's rather an observation. Can we have the slides in English? It is Paolo Bettiga, Italfarmaco. There is a person asking whether you can have the slides in English. They are ready. I can send the slides in 2 minutes. Paolo, no, it's okay. It's okay. I've had the question via chat. Thank you, thank you, thank you. So that you managed. This is the great added value of these international conferences. And we are very glad we are doing this in remote, but of course we don't have the possibility of meeting, of exchanging experiences and also having a good time, but also having a scientific exchange. We hope we can have that possibility very soon. Sorry. Sara Cazzaniga is telling me that the slides are already there in English, in real time, Thank you very much indeed. I wish to thank all our speakers. And now the floor to Cristina to introduce the next session.
Ricordo a tutti, anche a tutti I partecipanti, che potrete trovare la registrazione di questa sessione qualora voleste rivederla o qualora conosceste qualcuno che se l'è persa. Già quella di stamattina è disponibile sul sito www.conferenza.parentproject.it. Nel programma è sufficiente andare sulla giornata, sulla sessione, anziché trovare guarda la diretta, adesso trovate vedi la registrazione. E ora possiamo dare inizio alla sessione numero 7, dedicata agli aspetti psicologici del passaggio dall'infanzia all'adolescenza.
Okay, so the recording is available on our website, and now session number 7. The session will be chaired, as you can see in our pink colored screen, by Pugliese and Dauria. Well, again, they need no introduction, but we like introducing our hosts to you all the same. So bye in the meantime, bye to those who are leaving the session. So Tiziana Dauria is well known all across Italy. She's been working with Parent Project since 2009. She's indeed one of the best known faces, and she has been behind, if you wish, the counseling center where she was was indeed a very early worker. She is the coordinator of all those responsible for the centers in the different Italian regions, whom, by the way, we wish to warmly thank. Some of them you will see tomorrow. Indeed, their job is precious for all our families. You know, conferences like this are good also because they allow us to look each other in the eye. Well, that's yet another reason why we miss it. Anyway, Tiziana is the one we always go to when we need to do something particularly difficult, so to speak. And then Marika, you have already met her. She has introduced the trial video together with our president. Again, she carries out a very important work for families and for us staff members. So now the floor goes to Tiziana. I can see you are all with us, so I'm sure we'll feel very happy and moved today too. So you have the floor. Thank you very much. Thank you, Cristina, and good evening. Now, starting from diagnosis, patients and their families' lives can become very difficult. Hence, the relevance of the social aspect. And indeed, this session number 7, will precisely orbit around the psychological aspects of a DMD boy moving from childhood to adolescence. Of course, we want to involve all stakeholders, physicians, parents, and siblings. Actually, we did the same yesterday regarding childhood. So this time we are considering the passage into adolescence. Dr. Monica Pane, child neuropsychiatrist, is going to be interviewed. She's also a professor at the Cattolica Sacro Cuore University in Milan. She will be telling us about the change in time and the need for a multidisciplinary management and that should focus the whole family, not only the single patient. Indeed, once this neuropsychiatrist manages the patient, he or she will have to be on the side of the family, to accompany them through the boy's passage into adolescence when aids become less obvious, not to mention the emotional side, which is also very delicate. And indeed, what the professor tells us during the interview is very informative in this respect. Mom, Davide's mom, her name is Gloria, will also be interviewed in how in their family they have got organized, both for the sake of the boy and for the sake of the rest of the family and her own couple. And then we'll probably understand more about the DMD people's feelings through other interviews. For example, the one with Madeleine and Michele, two siblings. Their interviews revolve around the meaning of all family relationships that can allow to overcome difficulties without ever giving up and letting possible changes make one feel pessimistic about it. So now the video will be shown. My name is Vilma Dal Pre. I am the mother of three: Davide, 20 years old, Matteo, 18 years old, and Gloria, 12 years old. Matteo, the one in the middle, is a DMD young adult, and we live in Castello di Annone, which is a small town near Asti, northern Italy. Hello, my name is Michele. I'm 18 years old, and I study human sciences. Hello, my name is Madeleine. I'm 24 years old. I live in Rome, and I am a beautician, as well as Michele's sister. My name is Marika Pane. I am a pediatric neuropsychiatrist. I work as a university professor in Rome, actually, not in Milan, but in Rome. And I also work at the Gemelli Hospital, also in Rome. I've been working in this field for the last 15 years. And so far, some 150 DMD patients have been examined by me. I love my job, and I hope that my patients can feel how important they are for me through possibly my smiling face and the passion that I use in whatever I do. What about the changes that you have observed in moving from childhood to adolescence for your boy? Well, basically the need for independence, wish for independence, and I'll give you some examples about this. For example, Mario, my husband, and I would sometimes go to the cinema or to have dinner whenever that, of course, was possible, or else we were supposed to take the youngest daughter, Gloria, to a volleyball match. Well, he was always very, very happy about that. The first time he showed that was on the occasion of a small trip he did with the rest of the classmates to the northern Italian region where the First World War was fought. Actually, the assisting teacher did not feel like being on his own. We were doubtful. We decided he should actually be allowed to go. We drove there and were there on the evening of the first day, and we were just supposed to help him go to bed at night and get up from bed in the morning. We could never have either dinner or breakfast in the same hotel as the one of the students, because we were not supposed to be seen by our son's classmates. But after all, it was a sort of a holiday for us too. As for the international conferences organized by Parent Project, well, he never wanted to come to Rome with us, also considering that he could spend 3 entire days without us around. Michele, what about the changes from being a child to being an adolescent? What about your relationships? Well, when I was younger, I was afraid of so many things. Mainly, I was afraid of going to school. I feared I might fall, and I was also afraid of the dark. But as I became a teenager, I felt like with my wheelchair in particular, it was much easier for me to go to school, for example. So it was better for me. I have just gone on with my life. Madeleine, did you notice any changes in Michele's moving from being a child to being an adolescent? Well, the one change I noticed is that when he was younger, well, first of all, he was my little brother and made me so very happy. But then, as he moved into adolescence, I could see things got more difficult because he has a difficult gait. He had, at least before the wheelchair came about, and I always tried to protect him. But then he started using the wheelchair, and we both thought that was a good thing because after all, he felt supported. He didn't feel like he was going to fall over. And now that he is a teenager, although I can still see him as my little brother, there's nothing I can do about that. But he is certainly a teenager, and of course, he uses the electronic wheelchair, which is, of course, even better because he's more autonomous. As for the emotional side, well, of course, before the wheelchair came about, we could realize it was a very, very difficult time.
Quando c'è stato questo passaggio?
Do you think he has changed from an emotional viewpoint after this shift? Yes, because before that he had lots of anxieties. He was afraid of going out, whereas with the chair, he certainly did better. The care of patients in this passage, in this shift from childhood to adolescence. Well, it is a very important moment. I started more than 17 years ago working on neuromuscular diseases, and the care, the management of care of DMD boys has changed completely. And even more so for this transition moment. So this shift to adolescence, we have learned a lot about this disease. We have learned to manage complications much better. Luckily, our boys tend to walk for a longer time, thanks to steroids, for example. I mean, therapy has changed the story of the disease. Our children reach adolescence and still they are able to walk or to make just a few steps autonomously. And of course, the passage to the chair is an important moment, is a painful moment for them, for their families, but for us as well. But certainly we are better able to guide them towards this painful moment that is the moment when they start using the chair. What difficulties your son might have had at the emotional level vis-a-vis the social and the relational life, and how were you able to help him? Well, the difficulties, well, from the emotional viewpoint, well, it is difficult to answer this question because Matteo doesn't share his feelings or thoughts with us. He's always calm. So we tend to think that he hasn't had major difficulties. As for social life, up till now, he has not given up. And before the pandemic, say, he was always going out with groups of friends. Sometimes we have had some issues. For example, when they would go out with motorbikes, or some of them would have a driving license. And so he was not able to go with them. the only solution was bringing him to the place where they would go. But in the same day, these young people would move from one place to the next. And in that case, of course, he had to give up. We have always tried to accompany him and to make him happy, and we would sort of unload him somewhere where the others would not see that he was being accompanied. The problem was, what time was he supposed to get back home? But I mean, that is a problem for all teenagers who still don't have a driving license, so where they're not autonomous. The time when he goes to bed, well, that is always the origin of many clashes between Friday and Saturday. He would like to go to sleep anytime. He wants to be the one who decides. What is obvious is that he wants to choose and decide the hour. But since we must help him to go to bed, and we are tired at the end of a long day, so we quarrel. And of course, he is unhappy. In your family, how did the relationship with your parents or your sister changed? No, not really. No, there were no clashes. No. They have accepted your changes, your growing up, of course. As for the family setup, so parents and the type of relationship you have, between you and your brother and you and your parents, have there been changes in this phase? Well, yes, essentially yes. When you have a younger brother, of course, all the attention is concentrated on him. Of course, in a situation such as this is even more the case when there is a disease such as DMD. So being a sister is not easy, because all the attention are on the little boy, and so we are sort of set aside. We try to create as few problems as possible. What about the relationship between you and Michele in this phase of adolescence? Well, I'd say nothing. There is always an excellent relationship. We spend a lot of time together. Not many changes. What are the changes you observe in this shift from childhood to adolescence with regard to the body, the emotional state, and the social relationships of your the social aspects? We must consider different aspects. It's not a disease that only involves muscles, even though, of course, muscles are the most affected, what we see. But our patient may also have cognitive impairments, school problems, or behavior problems. They may have ADHD, and there are also some boys with an autistic spectrum. So when we start caring for one of these children who's going to become a teenager and then an adult, we must also consider a number of comorbidities that may be present in our patient. So it is a multidisciplinary approach. We are managing the care of the child, the parents, his siblings, his grandparents, uncles, aunts, and we try to manage all these people so as to share a common root. if DMD is accompanied by other comorbidities and problems, the situation to be managed is more complicated, more difficult, not only for us as carers, but for the family, because in that case, the load is really impressive. Some years ago, I had this diagnosis, the DMD, and then there was an autistic spectrum. And this dad, with tears in his eyes, said, well, not only my son is a DMD, but also having this extra diagnosis for us, it's really too much. It is, I mean, the load is really huge. And I realize that is the case. This is an important problem to be considered. So when the child grows up, when he becomes a teenager, a young adult, if there are these extra problems, well, the load is really heavy for the family. So one must consider different aspects and situations. Well, this shift from childhood to adolescence, what did it mean to you, and what changes did you observe in your family setup and the relationship with him and the other siblings? Well, the changes we observed are really changes from one day to the next. Also, in this year, that was really heavy and difficult for all. The school asked these young people to really have a great ability to adapt, to adjust. We have a very large house, and each child has his own room. We prepare the books on his desk, and he has his own PC, and we go to work also when he stays at home. So he organizes his time, so he sets a timetable with his support teachers. He sets also all the appointments with the people who help him for history and geography, and also with the physical therapist, and also with another man called Paolo, who is his personal assistant. Well, parents, we as parents have always tried to make our 3 children autonomous, independent, say preparing his school bag or the management of time during the afternoon and evening, with time for playing, homework, and sports, without us necessarily stepping in. With Matteo, I think we have reached this goal. And of course, that is very rewarding because, for example, we don't have to make appointments for him and we can work at ease without thinking about what he is going to do. And we have also found some space as a couple. And I believe that is very important and very healthy for the balance of the family. As for the other children, his siblings, well, we have always tried to avoid for them, I don't know, having to help in the things that pertain to Matteo. And we try to respect his needs without having to ask them to do things on our behalf, so that all of them feel useful, but no one is really indispensable. Maybe this has not contributed in the creation of a real team. So from time to time, what happens is that we or the brothers or the siblings, depending on the situations, well, sometimes there is egotism or selfishness, but at least each one of them feels free to do whatever he or she wants to do without any obligation towards the others. At the social level, have your relationships changed, your hobbies? Well, hobbies, I have many hobbies. sports. So I have a future in sports. Whereas, but no, at school I've never had any problem. I've never had any bully, or I was accepted. I still am accepted. At the social level, have you observed changes in the life of your brother at school or in the other situations? No, at school the answer is no, because his schoolmates has always had a great time, but with professors, with the teaching methods, they don't truly realize what disease is about. They are still not so well informed about the disease. So sometimes we have had teachers who would not understand much about the needs and the difficulties that Michele might have and the help that he might need. Whereas if we're speaking about social contacts, he has a very nice personality, so he has a very good relationship with all. But I've noted that people look
il suo rapporto con il paziente in questa fase di
about your relationship with the patient in the passage into adolescence? Have you seen any changes? Because of course you have known these boys since they were actual boys, so I'm sure you can be a sort of a point of reference, you know, for the boy becoming a young adult and of course his family. So have you noticed any changes or nothing at all? Well, regarding the relationship I have with my guys, as I like calling them, is quite a special one. You know, I am almost like their mother. You know, I often like to take the child by the hand and take him around. Of course, further to the diagnosis, quite obviously the child will feel like everything will be a problem in his life. But then he and his family will realize that this may not always be the case. But of course, I need to be there on their side as they realize that. And therefore, we may also want to change our approach. This has been the case for quite some time, I might add. Of course, when we are talking about young adults or even adults, well, I try to engage in a more personal relationship. I ask them to call me or write me, even without their parents knowing them, because they may want to tell me something that they want to hide from their parents. So they are welcome to do so. And of course, it depends. I mean, I don't go like that with all of them, but for those whom I have personally known for quite some time, it is quite natural for me to move on to a personal relationship. Otherwise, there's always the presence of the parents in between. But they must know that I always have time for them, also for their newly arising needs. Not, of course, to mention their, simple feeling like they want to cry, well, they can do whatever they want with me. I will always remember one of them who's really very dear to me. He was very angry because he was trying to walk and just couldn't. And he started, yelling at me and swearing at me. And I said, look, I love you. I have never been long insulted by anybody, but since I love you, I'll let you do that. And since then, we've always laughed at that, looking back. So this is how I would like them that they see me, the person whom they can use, if you wish, also to simply express their feelings, both good and bad. Sometimes they, for example, they graduate and they text me, they keep me posted about their achievements. I have just been told about a degree in engineering, and I received the picture of this young man having become an engineering graduate. I was very happy because that is part of our own life, in spite of their difficulties, these young adults can still make it in life. Do you think your son has reached a certain degree of independence, and what have you done to that purpose? Well, actually, last June, it was the first time that the issue emerged. So it was the beginning of the summer, but he had fallen and broken his thigh bone. So we thought we would have to ask for help. So one of the school teachers suggested I should call a former student of the school, who then referred me to a friend. And it's a university student. His name is Paolo. At that time, he did not have a driving license, so he used his bike to come to our house every morning. And during the school year, so after the summer, he is still coming, but only at the weekends, or sometimes on Sunday morning or on Sunday night, based on Matteo's needs and our own needs. For example, that was the case during one of our conferences or during summer holidays. And what has happened is that Paolo has come to live with us, so he's always there for Matteo. He helps him, I don't know, even, keeping his wheelchair clean, but they are friends, basically. They use the PlayStation together. In administrative terms, we first wanted him to have a fixed term contract with us, but then through the institution that in our area is responsible for social affairs, we decided we should view him in a foster framework. So we get a contribution from that institution, a half, and the other half from the local health unit. Any strategies that you have implemented to you know, to go into your adolescence? Well, when I was younger, I saw a psychologist. She helped me overcome my fears. And I developed many qualities, namely courage and determination. Which strategies do you think Michele has implemented? Has he asked for help, and how? Well, Michele has been helped by a psychologist when he was much younger. He was still attending primary school, but I mean into a high junior school. Actually, I used to take him, and I was there helping him come to terms with the changes he was undergoing. Do you think that some previously unexpressed qualities have emerged? I shouldn't think so, but he came out of those meetings more self-confident in order to overcome his fears. And what about you? What about you? Any strategies that you have implemented, either practically or emotionally, to be of some help? Well, sort of, if you wish, and not in a really positive way, quite frankly, because until I was 16 years of age, I really tried not to show that made me feel bad. So I tried to hide my unease, and I just went to school and, you know, went on with my life as though nothing different had changed. But then I turned 18, and that was the beginning of my awareness of what was happening around me. It was hard. It was hard, but I did manage to actually make this grief go to the right direction. How difficult is this passage into adolescence for both, I mean, for the patient and his family, and for you, for clinicians? Well, first of all, they must accept the wheelchair. And this is really like a bereavement, you know, it is something that patients and their families shall go through. You know, parents don't like the idea of having a wheelchair at home. Sometimes they wanted to be kept in the garage, whereas I see the wheelchair as a tool for the boys' independence. You know, they may go out and have a pizza with their friends, but we also leave that as a bereavement, because it's the obvious confirmation of defeat, of something where we have failed. But once that first phase is over, then we all realize that adolescence is there to stay. It may be more difficult than, say, normal adolescence, because, of course, there's a high degree of disability. And then there's a bureaucracy, you know, and all the problems are connected to going to school, to traveling. So I can see why this is a difficult time for parents who feel particularly tired by that time. And I feel like I want to relieve them from this burden, because this this is also our task, by the way. Now, in social terms, what changes have you noticed now that the school is over? Well, actually, Paolo will be getting his graduation this coming spring, so he'll start working, and therefore we'll have to find someone else to help Matteo. We have always had our families and friends on our side, and sometimes we'll look back and consider what has gone, all this time. And we have, quite frankly, always tried to get the help of other people. Since he was in primary school, there was a lady who was helping him with homework. And then when he was in junior high school, a friend of our families who had lost his job would help him also, go around. Every year we sent Matteo to this school summer camp or the holidays organized by our parish. And in these past few years, he has even gone to Dynamo camp. Actually, Matteo has always made many friends. Some of them are still friends. For example, a boy he met at the kindergarten came back into his life when they both went to high school. So, of course, that made him very happy. He finds it very easy to make friends and talk about all possible subjects.
Preoccupazioni, soprattutto quando
especially in some cases, of course, there were anxieties and concerns on our part. At the camping, for example, they called us because they had hit his head and they were taking him to hospital. And I still remember those days. There was a trip in the mid-school where they went skiing in Valle d'Aosta. I was counting the hours and I could imagine him unstable, sliding on ice at the first slope, or when, I don't know, when they called us from this mountain vacation. He was there with the parish group and they had done a path on that day, carrying him on the shoulders. And the place where they stayed had stairs. And they told us, oh, it's not a problem because older boys are carrying him up and down. Luckily, everything went well and we were able to overcome this moment of separation, of letting him go, of letting him live his own life. He has always been with other people, so not only with us. And of course, that has helped him in developing in a way that is different from what it might have been the case if he had stayed just with us. What are the projects for the future? When I finish the fifth year, now I have the A levels and I'll go to college. And I want to work in the area of sports journalism. Sports journalism. I want to be a sports journalist. This is your plan? Yes. Then, gradually I'm going to find a job, or if possible, finding a girlfriend. Why not? What is your idea what your brother is going to be in the future? Oh, what a question. What a question. I imagine that he can become a sports journalist because he's very fond of football. And then, calm, I'll be here for him all the time. What about your future? Well, this question tends to be even more difficult than the first one. I don't know. I don't know. Of course, I want to have self-fulfillment also in my job, not only in my private life. I'm working hard as from today to build my own future, live on my own, having my own flat. And I hope when COVID is over to be able to organize a trip with my brother. And what about the future? We are, of course, we think about the future. We think about the future. The first objective is finding another personal assistant, just as good as Paolo. Matteo wants to go to college, so we'll have to organize the trip and organize his days differently, and we'll get some help because by ourselves we wouldn't be able to do that. And also for him, I mean, he wouldn't agree, he wouldn't accept the idea of being helped just by us. Well, and then, you know, there is a message that I think I can send to DMD and BMD patients for this moment of shift from childhood to adolescence. Well, never lose hope and go on doing things with the same enthusiasm, the same passion, regardless of the fact that we are no longer able to walk, that we have to use a chair. But still, I mean, as my daughter says, it is not really important how you walk, but rather where you go and with whom you go. So the message I like to give my boys is the following: keep fighting, because we fight with you and for you, to give you hope, to find a cure for this disease. And the different therapeutical trials make us hope that something may change. So I mean, you must keep up hope. If you were to send a message to other boys or other parents, what would you say? Encouragement. You mean to encourage them? Never give up. Well, never feel down, because you must face situations for what they are. I feel I've grown a lot. Yeah, because staying at home for 1 year, I mean, I really had to make a big effort. You must keep seeing the rosy side of things. What message would you send to other siblings or at the community at large? Well, as for sisters, I'd say, well, first of all, try and find enough strength to make your dreams come real. And you must always react. The accident I had this fracture to my femurs, and all that happened, well, I fell and all the times I had to go to hospital, I was almost going to die, but luckily, gradually, with my determination, I managed, and I went back to the chair. So never give up. You must put up a fight, put up a good fight. Well, to the rest of the world, I'd like to say that we really hope in research, we keep donating, and we hope that sooner or later they'll find a cure for rare genetic diseases.
Ecco, grazie.
Well,
Davvero a tutti i partecipanti.
thank you. I wish to thank all the participants for this contribution. It is difficult to talk now, but I'll do my best. It's also difficult to add something to what you all have said, but I'll give it a try. And now I'll do some screen sharing. I want to show some slides.
Perfetto. Appunto, abbiamo ascoltato dalle varie testimonianze.
Well, the different people who were interviewed told us that this shift from childhood to adolescence is a very complicated moment, a moment of crisis and change. And since in patients who have a motor disability, the changes in the body don't go hand in hand with emotional and psychic development, sometimes the speed of these changes, of course, is an issue. In this case, the change is unavoidable, but it's also useful to build up one's own identity, and so creating adults that have their own personal strength. So this idea of independence without the presence of parents. One of the elements characterizing this phase in DMD and BMD boys is the need to adjust. They have accepted the diagnosis, but then things change. Changes really take place, and you have to readjust, and the feeling that you have to start from scratch. And this is precisely what Michele told me as to his fears before being able to use the chair. And in this case, of course, literature tells us about also the evidence provided by the other members of the other stakeholders. Well, all this happens far better if he has been well prepared by his parents. So this shift from ambulation to the chair, of course, it must be elaborated. It is, of course, a moment of pain, a moment of bereavement, so to speak. Some factors were identified for the building of identity, and the first factor certainly is space. Space is understood as what is around our body. And we know that boys who have a neuromuscular disease live their body as something that has been damaged by the pathology, and that affects the image they have of themselves, so self-esteem. So their self-esteem, and the body changes. And it becomes an adult body with its pulsions and emotions. Michele told us that he would also like to find a girlfriend. Why not? And besides, in this phase, well, friends, schoolmates at the same time have their own need to find independence. and the gap you may have between DMD patients and their peers, well, may increase. There is this need of becoming autonomous, and it is difficult to set a boundary between autonomy and independence. Vilma said, well, we had to be there, and at the same time, we had not to be there. We should not have been there. And the image we have of ourselves is also the image that is mirrored by others. If the this image, if the mirrored image is always negative, of course, our self-esteem is damaged. Madeleine told us that Michele has always found people accepting him, also among his peers. And of course, that has contributed in creating good social competencies in Michele, who always managed to do well in his social situations. So there are the individual, family, and social aspects, and they are intertwined. And that is precisely what we have to work on to promote resilience at the individual level. Well, of course, there is anger. But as in the case of Michele, there are also fears that have emerged in this moment of shift. Anger towards themselves for the body that's changing vis-a-vis their parents. They would like to get away from their parents, but they still need them. And also anger vis-a-vis the peer group, and also an anger towards the future. Certainly, this young man feel lonely, and that may lead to isolation, social, affective isolation. And so these boys who have a disability can be seen in a different ways. It is the gaze of other people, the people around her, around her family, around his brother. This is something that Michele has never felt. He has reacted in a different way. Why? Well,
che possono determinare e quindi diminuire
Some
l'impatto.
factors have been detected in the literature whereby to reduce the impact of such emotional stress. So first of all, the so-called coping, that is those strategies we implement in order to indeed cope with the most distressing events in our life. From Michele's interview, we have learned that, for example, the wheelchair was seen as a tool to become more autonomous, not to mention the overcoming of some fears that he managed to do thanks to the psychological aid, whereby his emotional and psychic balance was kept all through. And then all of them, if the coping had been avoiding, well, in that case, the process would have been much more difficult. But of course, the support that one may get, even informally, by one's family or one's friends. On the other hand, the support may also be formal, provided by institutions or professionals. And this is, of course, very important because even the psychologist helping Michele actually ended up by helping the whole family. And then the participation. Well, here the peers become even more important than families. As Vilma said, it was hard for her to let Matteo go, but it was an important passage and apparently a successful one. So there are many resources, many strategies that one may implement. Yesterday we talked about the time of the diagnosis communication, very important to help the patient and his families to process the emotions that derive from that, as Madeleine rightly said during her interview. So I believe we need to understand the ongoing changes out of our, of course, drawbacks, but also of our assets. Michele is certainly a very nice guy and also one who is an optimist. This should not be put aside. But then, of course, we must include we must include in this framework the role that may be typical within a family, and that is replaced by another kind of approach that derives from having a disabled child in the family. In other words, the family must provide children with the rules, whereas they'd rather, provide the child with the protection, the disabled child with protection. And this is wrong, this is very wrong, and it can engender some anxiety processes. So this is a role that should be kept at all costs. We talked about the social network, we talked about friends, and therefore we must say a few words about the time these boys spend at school, where most of the notion of social inclusion is derived. We often collect several experiences about this. In the video, Madeleine, for example, said the peers framework was always very welcoming, but not so for the teachers, who did not seem to fully understand the relevance of the disease. It is also very important to favor, these boys' social relationships, both at school and outside school. Matteo's experience and the experience of the other boys are clearly self-explanatory, because Matteo, before COVID-19, did manage to have a perfectly rich social life. And then what about the caregivers? These are very important figures because they allow for more autonomy to come about. As the physician said, Dr. Pane, of course, providing information about how to manage the different problems that may arise. Well, their work is very important, but they should also promote the use of aids that can precisely foster these boys' autonomy. And sometimes this entails bureaucratic problems, but promising all the same. And in any case, it must be a patient-centered approach. As the physician rightly said, it is the patient who may engage in a personal relationship with the physician, since physicians would also like to devote their personal time to patients. I'm sure I might speak for much longer, but we want you to have more time for your comments. But let me conclude with a quote from Dr. Pane's daughter. What's important in life is not how you walk or what you use to travel, but where you're going, and even more than that, whom you're going where with. So I would like to thank you all. Thanks a lot to all speakers. Please take the floor. I can see that Mario is now sitting next to Vilma, who I'm sure spoke for him too. I wish to thank Dr. Pane, Madeleine, and Michele, and of course their family, because they're great. But I'm sure that if they are great, it's also thanks to their parents. So would anybody like to add something to what you've said? I would like to congratulate Vilma and her husband, as well as Michele and Madeleine and their parents, because I often I often get in touch with this kind of patients, and therefore I can fully understand the degree of pain that this may have engendered. But I can see how well both Michele and Madeleine seemed to be doing, which is, food for thought, and especially hope for the future, because it is possible actually to be like that. I often tell the families they should be patient because they're going to see that with time they are certainly going to go through it all in a very different way. And Madeleine and Michele have clearly, testified to that. And the same goes with Vilma and Mario, because I do believe that especially for families where DMD boys are very young, they may have been extremely helpful. Thanks a lot. Well, of course we agree. And this is the reason why we wanted them to be part of our video. We knew their interviews could be helpful to the rest of our community. Good evening, everybody. We certainly want to thank Marica, Cristiana, and Roberto. Thanks for helping us have a dedicated space in the conference, and thanks of course to the whole staff. We would particularly like to say hi to the parents. We believe that as parents we'll never stop learning. We have gone a long way, but there's still a long way to go, and this has been possible also thanks to Parent Project. Actually, I'd like to ask all parents, all families to keep going, to keep engaging and committing to the goal of the association, because it's for the sake of our sons. We are the association, so whatever we do will be fruitful for all of us. So we shouldn't give up, as Michele rightly said. Thank you again. Thank you. And by the way, talking about socializing aspects, well, Matteo is now at the birthday party of a friend of his who has just turned 18. So he doesn't give up, that's for sure. Actually, last night, he was a bit, sad because he felt like his Instagram website that he holds together with Jacopo had not been given the right space, but this will be done. Don't worry. We know that that is a very, very relevant social network. We are going to use it very soon. Thank you. Thank you again. Thank you all. We would also like to thank you all. I would like to thank Dr. Pane for her kind words. And, you know, we have a motto, and the motto is let's keep positive. Let's not get overwhelmed, you know, by difficulties. We should always be brave in coping with life. Well, that was a take-home message that everybody has got. Don't worry. How old are you, Michele? Somebody asked. I'm 18. I'm 18. Well, you look younger. You know, you look younger with that bow tie. You look very nice and definitely younger. Thank you. Thank you. And bye, everybody. Well, anybody else? Would anybody else like to take the floor? Well, some is writing that somebody's writing in the chat that was a beautiful session. Thank you about that. Well, we would like from the studio to thank you all, to thank the people of the counseling center in particular, because yesterday, today and tomorrow, by the way, they have organized these windows within our conference that move us and make us feel very proud of being members of this association, because these are moments of sharing, you know, the people can use them to share their approach to life. In particular, I'd like to thank Vilma and Mario, as well as Madeleine and Michele. But Vilma and Mario, I might add, are the mom and dad who have most believed in our fundraising campaigns so far. They've always been very good at doing that.
Fare un appello a
to seize this opportunity also to launch an appeal to all the families. Vilma did it. Keep working on that. Well, we always seize this opportunity also to speak about fundraising, because it is really extremely important. And then I'd like, of course, without his authorization, I'd like to say that Matteo is also very active on social networks, also for Parent Project. Matteo Tosetti, together with Jacopo De Angelis, that you also see in our video, in the film of the conference. They have an Instagram page together where they post and share a lot of subjects linked to the pathology, but they also help us enormously in making our initiatives, campaigns known. So I'd really like to seize this opportunity to thank them also for that, because we are investing a lot on our patients. Here we have the parents are important, but we really would like to be an association of parents, and as staff we'd like to be governed by the patients. In the next executive committee, well, the greatest success for Parent Project itself would be have a patient as a president, one of our young men. That would be also a great success for our clinicians. who have seen them since they were kids. So thank you very much indeed. And if there are no other questions or comments, I'd like to recall that since we are a TV studio, well, we are without masks because we have swabs every day. This is something we liked very much. And we asked Tiziana and Marika, who are from home, but they would be together. They had, in fact, to carry out a swab as well. That was necessary to be so close, to sit so close. We are in smart working as I expect most people are. 1 year ago, we canceled the conference. It was a very difficult decision because still we did not have a decree, but we knew what was going to happen. And we haven't seen each other for 1 year, also with the staff, but we've been able to do a lot also to organize this event. That is, I mean, is quite successful, even though having a real life conference is something different. Where at the end of the 4th day, tomorrow, we convene the first session at 10. So we're not starting from the studio at 10, but we start with parallel sessions at 10. And the program of the parallel sessions, well, you can just click on the session and you can go there live. We'll have 2 parallel sessions, one about school in Italy and all the aspects of school, all the legislation that favor the presence of these DMD boys at school. That will be only in Italian. The second parallel session will be on domotics, and that will have simultaneous translation as well. At 11:30, we come back to the studio for an historical moment because we'll have a very important moment devoted to the sort of little sister of DMD, i.e. BMD. We did an impressive work on that, and we'll be sharing it with us tomorrow. And then we'll have in the afternoon some space for adult patients, both with regard to clinical and scientific aspects, but also from the psychological viewpoint. Well, that's all, folks, for the time being. Thank you, Marika, Tiziana, and all the National Listening Center and all our local representatives, Dr. Pani of the Rome Center, all the clinicians who stayed with us today, all the researchers for their everyday work, and also for their great willingness to take part in these initiatives and feel truly as a part of our community. We wish to thank our families, patients, and brothers and sisters. They are really incredible. Even though we don't have, the musical night or the dance as we used to have at the Argif Hotel, well, we try to imagine all that. See you tomorrow. Have a nice evening.
Arrivederci.